Good afternoon, all. Uh, Respected seniors, colleagues, postgraduates, we welcome you to the annual conference of Tamil Nadu chapter TNISG at Coimbatore. So, we'll start the PG program. I invite Dr. VG Mohan Prasad sir, organizing chairman, to deliver the welcome address.
Good afternoon, everyone. Can we hear? Can you all say good afternoon? Good afternoon? Louder? Wow. I hope you all had your lunch. Yes? Okay, good. So, Dr. Mugundan, thank you for inviting me to be on this stage. All the credit should go to one man, that is Dr. LVK. So please give a big round of applause to Dr. LVK, who's put up a brilliant program, a great academic program with all stalwarts in the front row. They're all leaders in the field. And I'm also privileged to be a part of this program. So I'm really, really grateful to Team PSG for making such a wonderful, academic schedule. And I, as the organizing chairman, I have a great pleasure in welcoming you for the next 2 days of, including today, 3 days of great academic feast. I'm sure you'll enjoy this program and learn as much. So, and the, the venue for Saturday night has been shifted, tomorrow night has been shifted to VV Farms on the Trichy Road. So that's not too far away, it's only 10 minutes driving time. So the evening program will be there. So I have a great pleasure in welcoming once again everyone, and salutations to Dr. K.R. Panisamy sir, who is holding the fort of Tamil Nadu ISG Foundation, and Ashok Chako sir is there, and all the seniors are here. So I have a great pleasure to welcome Matthew Philip, who's the Secretary General of Indian Society of Gastroenterology, and all our leaders here. So welcome once again, and we'll start. I think I'm just seeing Dr. Jayanti and Dr. Malati here, Prem, and everybody. Pirama is here. So happy to receive all of you here. So over to the MCs for, starting the program.
Thank you, sir. To kickstart the session, first our postgraduate program. The PG program course directors will be Dr. Professor V. Jayanti, Dr. Professor Malati Madam, Professor Ashok Chako sir, Professor Ganesh sir, and Professor Murli sir. The first session will be on a session on digestive oncology. For the session, I would like to invite the moderator, Dr. Sridhar Sundaram sir, onto the dais. And the panelists will be Dr. Tirumurthy sir, Dr. Murli Ranga, Dr. Vadivel Kumaran sir. Invite all the three panelists to the dais, please.
So once again, very good afternoon to one and all. And at the outset, I'd like to thank the entire team at TNISD, LVK sir, for this invite and this opportunity. So I think we're going to be talking an exclusive 2 hours on digestive oncology, and I'm going to be moderating a case-based discussion later. But in the meanwhile, we thought we should divide the topic into 2 halves. The first half, we have common GI problems faced by oncology patients. So we have 3 eminent panelists who are going to be discussing 4 common problems, over the next 1 hour maybe, and we can have questions from the students. And after that, we have a case-based discussion for 1 hour, wherein we are having some cases that you can present, that we're going to present, and some problems that the students can find the answers to. Okay, so without further ado, I'd like to invite Dr. Tirumurthy, who's going to give the first talk. So he's going to be speaking on nausea, vomiting, diarrhea, and nutritional challenges in patients in the oncology setting. So I think, Tirumurthy, if you can.
Good afternoon to all. I thank the organizers for giving me this opportunity present in this PG session. This oncogastroenterology, it is a new terminology nowadays. It is used for this gastro management of approach and management of gastroenterological issues in GI cancer patients. It is more or less, it is same with the other gastroenterological problem. There are certain differences will be there. Whereas in this oncogastroenterology issues, we thought of classifying into endoscopy related, luminal, nutrition, hepatology and community gastroenterology, of which today we thought we will be, it is a very huge topic, so we will not be going through details in depth of each and every topic. We are not going into that. We thought we'll give a bird's eye view on the main issues, how they are different from other gastroenterological issues. That was the basic idea, giving a bird's eye view of oncological oncogastroenterology. In the endoscopy, it can be diagnostic, therapeutic, and surveillance palliative, luminal, nutrition, of which today's session we have we didn't go much into hepatology and community screening except viral etiology. So I'll be covering on mainly luminal this thing for mainly enteral nutrition access, then chemo and radiation induced complications and other things. That is what I'm going to give a bird's eye view. I'll be very brief on this thing. So endoscopy assisted access to enteral nutrition, indications all we know because of poor nutritional status or vomiting, or it is because of medication access. Contraindications like uncorrectable coagulopathy, active peritonitis and hemodynamic or respiratory instability. These are relative contraindication. We have to take some precautions and we can proceed with the procedure. That is a relative contraindication. We have to take appropriate precaution. For that, we need when you are going for enteral nutrition, basic anatomy and the physiology of the system. Understanding of this is very important. Then we can take appropriate precautions. There are various enteral access route. One is nasogastric, nasoduodenal, or nasojejunal. Then comes the percutaneous approaches, gastrostomy, jejunostomy, or peg jejunostomy. Then it can be endoscopic as well as surgical. Today we are focusing mainly on the endoscopic methods. One is nasogastric route, another one is a percutaneous route. Other one is self-expandable metal stent deployment, can be esophageal, pyroluduodenal or neopharyngeal. Neopharyngeal is majority of the time patients come with after total laryngectomy, they will have a neopharynx, stricture will be there. They are usually difficult to dilate. In that also we can place a metal stent, that is the neopharyngeal aspect. Then comes the EUS guided gastrojejunostomy. These are the enteral nutrition access procedures done by gastroenterologist for the cancer patients. So I want to highlight some of the practical issues when whether it is a nasogastric or a percutaneous approach. When we are going for it, we'll have routinely we will be doing all this process like nasogastric tube, NJ tube placement, all we will be doing it. But certain challenges in oncology I would like to highlight. One is NG tube. NG tube placement will be sometimes it will be difficult, especially if it is a patient is having nasopharyngeal carcinoma or some cancer in the oral cavity or soft palate, hard palate causing nasal cavity abnormalities. In that case, we have to take precaution. Like we cannot straight away place the nasogastric tube. We have to place. First you have to place insert the guide wire through the nose. Then bring the guide wire over the guide wire. We have to place a nasogastric tube. That is the one thing. Another one is usually for oncological patients, nasogastric or nasogenual tube will be there for a long time. Especially if you have inserted too much inside the gastric lumen, sometimes this over the period of time, if it is not replaced in 2 months or 3 months, what will happen is the tube becomes stiff and the removal will be very difficult, nasogastric tube removal. Furthermore, it will be complicated by the if there is a stricture in the esophagus and post-cricoid stricture, then removal will be very difficult. We have to use various maneuvers and methods to remove the nasogastric tube. Under the fluoroscopy, we have different methods are there. We have to put a biopsy forceps, tighten it, then do the different maneuver, then we have to remove the nasogastric. So it is in oncology patients, we have to be very careful. At least once in a month, we have to change the tube if it is expected to be continued for a long time. Then NJ tube insertion, majority of the time, normally for gastric outlet obstruction, we place a NJ tube. In that patients, we have to discuss the different options to the patients. Majority of the time, we are not discussing. That is one important thing. Always whenever some coming with gastric outlet obstruction, we have to discuss with them. One is NJ tube, then duodenal stent or pyrolural stent, then coming for EUS, GJ. All these things we have to discuss. Pros and cons we have to discuss. Especially if it is a andropyloric growth with gastric outlet obstruction. Usually the patients coming to us, usually they'll have advanced cancer. So even if you place enteral stent, majority of the time functionally it won't be viable because the tumor will be involved in the muscularis propria, there will be atony and loss of peristalsis. The lumen will be patent, but the purpose will not be served. So in that cases, we have to very carefully, we have to assess how much is the tumor involvement. For that, how to assess, when you are doing diagnostic endoscopy, you have to inflate the stomach. If you are not able to inflate properly, that means the muscularis propria involved. In that case, we have to tell the patient, even if you place enteral stent, it may not serve the purpose, then we have to advise other methods, either by surgical if possible, or gastrojejunostomy, or other methods we have to advise them. That is one of the things we have to discuss. Then comes the PEG-J. We can, some patients will have a prefer for the percutaneous endoscopy gastrostomy. Some patient will have, because of some reason, they will have repeated aspirations. In that case, we can go for a PEG-J. So all these things we have to discuss with the patient, understand the anatomy. Accordingly, we have to select and tell them. That is one important issue, because here in oncological patients, always the anatomy is abnormal, and we have to see adjacent organs involved or not. Based on all these things, we have to give them the option and go for the enteral access way. Then another important issues in oncology is strictures. As compared to benign strictures, this malignant strictures are treatment related. Post radiation strictures, they will be very, they are very usually very tight, and the fibrosis will be very thick. Usually they will be refractory for dilatation. Sometimes you may have to use multiple methods to dilate, and the stricture also, it will not be in particular this, there will be lot of angulation because of the thickness. So you'll have a lot of difficulties that we have to take. Sometimes if we are going for a SG dilatation or CRE dilatation, the fibrosis is so thick, you may not able to dilate fully, the dilatation won't occur. In that situation, we have to prefer going for a, using the needle knife, we have to do the pre-cut on the, at the 4 angles of the stricture, then we have to go for a dilatation. Then only it will be possible for doing a dilatation. Second one, the length of the stricture, we have to be very careful. Otherwise, sometimes when you are dilating it, if the length of the stricture is very long, then there will be chances of complication will be more. Then the site, depending on the site, again we have to be very careful. In post-cricoid stricture, dilatation usually relatively it will be easy. Whereas in esophageal stricture, when we are dilating, especially malignant strictures, we have to be little careful. When we are dilating it, sometimes the chances of perforation, everything will be high. Because post-radiation, esophagus wall is a thick fibrosis, it is like a glass. When you are dilating full, it will open like a glass. It break like a glass, and it can cause perforation and other things. So that esophageal stricture, we have to be careful. Then pyloric PDO stricture, duodenal stricture dilatation, then anastomotic stricture, especially esophagogastric anastomosis, post low anterior resection strictures. We have usually these strictures will be very soft as compared to post-RT esophageal or post-cricoid stricture. This anastomotic strictures will be they are very soft. When we are dilating it, we have to take utmost precaution, should not perforate. Then coming to the neopharyngeal stricture, especially muscle flaps. When they are doing laryngectomy and they are putting pectoralis major musculocutaneous flap, usually these flaps will be either they are very tight, or they are recoil easily. When you are dilating it, usually they'll go easily, they'll go up to 14 millimeter or 15 millimeter. Once leave it, it will gets recoiled because of the muscle. In these situations, we may need multiple dilatations, or sometimes we have to place a fully covered metal stent. Later we can remove it. Then comes the biliary strictures. These are different methods I have discussed. Using Savary-Gillard dilator, we can do the dilatation, or CRE balloon dilatation. If the stricture is very tight, and usually the CRE balloon dilatation will be better than the Savary-Gillard. If the stricture is, the fibrosis is too thick, It's a relatively long segment stricture and it is angulated. Always CRE balloon dilatation will be better than a Savary-Gillard dilator. Then other methods endoscopically what we are doing is fistula closure like surgical anastomotic leaks or fistulas, then rectovesical fistula, tracheoesophageal fistula that we can manage endoscopically. Various devices available, hemoclips, over the scope clips, and fistula closing device like using ASD devices we can close the tracheoesophageal fistula. Coming to the diarrhea, one of the important most common complication or side effects occurs with the chemotherapy or radiotherapy or related to surgical procedure. The various causes I have mentioned. It's a neoplasm itself can cause diarrhea, chemotherapy, surgery, radiation and other causes. Apart from this, patient can have other causes of diarrhea. Whatever mentioned in the slide, it is pertaining to the oncological causes for the diarrhea. Patient can have other causes. So when you are approaching a patient with diarrhea and cancer patients, we have to think other causes as well with the background of these causes. So these are the neoplasm itself can cause directly diarrhea. There are carcinoid syndrome, colon cancer, lymphoma and medullary carcinoma, thyroid and other things. These are the chemotherapy induced diarrhea. What are the drugs or regimens which can most commonly cause diarrhea? That is capisdapine, irinotecan, Folfox, IRI, and bolus fluorouracil and folinica. These are the chemotherapeutic agents most commonly causes diarrhea, and we have to take utmost precaution. And if diarrhea occurs, we have to manage accordingly. There are other targeted therapies. Again, they can cause diarrhea. No need to remember all these drugs. We can have the list of drugs pasted in the department. We can go through that. So just we should know these are all the chemotherapy drugs can cause diarrhea. Then we have to, whenever the patient after receiving chemotherapy developing diarrhea, we have to grade the diarrhea, and based on that the management will be little different. When we are approaching the diarrhea, apart from always we should not go with it is only chemotherapy induced diarrhea, we have to think of other causes of diarrhea, then accordingly we have to approach. This is a common terminology criteria for adverse events for diarrhea. There are grade 1 to grade 5. These are the warning signs of diarrhea. Anybody is having diarrhea. These are the warning signs like massive dehydration, fever, peritonitis, blood loss, delirium, and other causes. Why we are saying warning signs? These warning signs, one important thing in oncology patients, it may not be there always. So we have to be very watchful. What are the causes, how to approach that, all we know. But in oncology patients, usually because of the poor nutrition, chemotherapy induced, their immune response will be poor. So they may not manifest all the signs of warning signs of any inflammation or infection. We have to be very watchful for the deterioration and other thing. Then only we can pick up the warning signs. So management routine, apart from hydration and antibiotics, other thing. Generally in diarrhea in oncology patients, we liberally use loperamide. We may start with 4 milligram and 2 milligram every 2 to 4 hours. We can go up to 16 milligram, provided this is a grade up to grade 2 or 3 diarrhea. If it is going beyond that, usually we have to suspect underlying infective cause. Then we have to try to avoid loperamide, and we treat with antibiotics and other symptomatic treatment. Then actreotide is very useful in diarrhea in patients with cancer patients. We can give 100 micrograms subcutaneous TDS, or we can give 50 microgram per hour infusion. It is very much useful. Usually it is stomatostatin, actreotide, other pan inhibitors of all this GLP, vasointestinal peptide, pancreatic enzymes. Thereby it decreases the diarrhea volume and frequency. So actreotide is very useful in diarrhea in cancer patients. Uridine triacetate, it is a pharmacological antidote. Steroids, some patients, they are not, frequency is not coming down with anti-motility drug, then we can use budesonide. Then bile acid sequestrant, especially surgical, post-surgical diarrhea, suppose bowel resection, all these things, we can use bile acid sequestrants. Neutropenic enterocolitis, one of the life-threatening condition. We have to be very careful because patient with severe cytopenia presenting with diarrhea and there is a hypotension, usually there is a criteria for that, how much for neutropenic colitis. We have to be watchful in these patients. We have to treat aggressively with the antibiotic, hydration and parenteral nutrition and bowel rest. Otherwise the mortality rate will be very high with neutropenic colitis. These patients won't give any inflammatory signs, just they will have a diarrhea, and if you examine them carefully, closely, daily watch, They'll have some abdominal findings like ileus, and they will have hypotension. These are the signs will be there, but the outcome will be very severe and mortality is very high. Coming to nausea and vomiting in oncological patients, it can be chemotherapy-induced nausea vomiting, radiotherapy-induced, or chemo-radiation-induced, or post-operative nausea vomiting. These are, I'm not going to the detail, mainly in oncological patients, main mediators of nausea vomiting is, one is the serotonin, another one is neurokinin 1. These are the two. Serotonin works by the peripheral pathway, whereas neurokinin works in the central pathway. These are the two pathway importantly mediates the vomiting, apart from other receptors as well, like acetylcholine, histamine, dopamine receptors, but main two mediators responsible for nausea and vomiting in this thing is peripheral pathway, it is serotonin mediated, whereas in the central pathway it is a neurokinin 1. That is where the majority of the drugs in the management of nausea vomiting will be revolving around these two medications. So these are the causes for vomiting in cancer patient, nausea vomiting. One is a chemotherapy, radiation, surgical, and other non-chemotherapy medications, gastric emptying, bowel obstruction, brain or mets, pain or anxiety, infection, sepsis. These are the causes for nausea and vomiting. So few words about chemotherapy-induced nausea vomiting. As I have mentioned, serotonin is the main mediator of a peripheral pathway of chemotherapy-induced nausea vomiting. So the endochromaffin cells in the intestine, because of chemotherapy there is a free radical release that activates endochromaffin cells, leads to serotonin activation, leads to vomiting center activation, leads to vomiting reflex. The chemotherapy-induced nausea and vomiting can be acute within 24 hours of chemotherapy, delayed 24 to 5 days, breakthrough or anticipatory or refractory. It can be any one of these things. The risk factors for CINV is anticipation of CINV, anxiety, depression, females, alcohol use, first cycle of chemotherapy, history of previous, all these things are risk factors for CNV. We have to assess all these things and we have to go for this. These slides, no need to remember all this. These chemotherapeutic agents are intravenous or oral drugs. Accordingly, based on the emetogenic potential, they are high emetogenic or moderate, low or minimal, like that. These are the drugs with high, that means more than 90% of chance of nausea and vomiting. This is a moderate, that is 30 to 90%. Then comes the low risk, that is 10 to 30%. Then comes the minimal, less than 10% chance of nausea and vomiting. These are all the drugs which are, when we give it in the intravenous, these are the chances of developing nausea, vomiting. These are oral antineoplastic drugs, that is classified moderate or high if it is more than 30% of chance, and these are the drugs. Then emetogenic risk for less than 30%, minimal or low. So for intravenous there is a 4 classification, for oral drugs only 2. So we have to keep this chart in the wards or this thing, then we can identify these are the drugs comes under what category of emetogenic potential. Then for high emetogenic risk anti-neoplastic agents, we have to give 4 drug regimen. These and all, if suppose we are giving a high emetogenic drug, on the day of before giving the chemotherapeutic agents, they give these are the 4 drugs. That is NK1 receptor antagonist, serotonin receptor antagonist, dexamethasone and olanzapine. From day 2 to 4, they give dexamethasone, olanzapine for 2 to 4. Other anthracycline compliant cyclophosphamide, same 4 drugs. From day 2 to 4, olanzapine should be continued. What are all these drugs? I will show in the subsequent slides. Moderate emetic risk neoplastic, then we have to give 3 drug or 2 drug combination. I'm not going into the details of this each and every one. For low emetic risk, single dose will be, single agent will be sufficient. For minimal emetic risk, usually we have to risk stratify if required, or the patient is developing vomiting, then we give for this thing. So these are the drugs comes under NK1 receptor antagonist, aprepitant, fosaprepitant. FOS means pre-drug. So netopitant, pro-drug. Then netopitant palanositran, NEPA, that is called NEPA combination. Then FOS, netopitant, palanositran combination. In the 5-HT3, aprepitant, these drugs act in the central mechanism, NK1 receptor antagonism in the chemoreceptor trigger zone in the medulla. Thereby they act. Usually they are given as a single dose before the chemotherapy. 5-HT3 antagonists, these are various 5-HT3 antagonists, granisetron, andancetron, palanositran, of which palanositran is most commonly used because it is has a high affinity almost 100 times more than the granisetron or ondansetron, and long duration of action. It is usually the half-life is 40 hours. That is why in chemotherapy-induced nausea, vomiting, we use palonosetron. Ondansetron and granisetron not used because ondansetron, if we have to give very high dose, like 16 to 24 milligrams we have to give. That is very high dose. It has a cardiac side effects. That is why we don't use ondansetron in chemotherapy-induced nausea, vomiting. Instead, use the palonosetron, which has a half-life of 40 hours and it has 100 times more affinity for 5-HT3 receptors. And dexamethasone, then we use a 12 milligram oral or IV dose we have to use, then followed by 8 milligram from day 2 to day 4. Corticosteroids, the mechanism of antiemetic action is multiple: anti-inflammatory, direct central action at the solitary tractus nucleus, interaction with the neurotransmitters, various neurotransmitters, maintaining the normal physiological functions of the organ and system, regulation of hypothalamic pituitary axis. Olanzapine, it is used 10 milligram or 5 milligram dose. Olanzapine, again the mechanism is it acts almost all the receptors pertaining to nausea and vomiting, especially in the dopamine, serotonin, all these things. Also it usually it is an antipsychotic drug. It has as well as anxiolytic effect. So anticipatory nausea, vomiting, for all these things it will be useful. It has a multiple levels of mechanism of action. In general, the antiemetic has to be given as per the emetogenic potential of the chemotherapeutic drugs. If the patient is not responding in spite of that antiemetic drug, we can use adjunctive drugs like lorazepam. Adults treated with multi-day anti-neoplastic therapy, we have to think of other agents for giving, and as well as simultaneously we have to continue the antiemetic drugs for the longer period. In general, it is recommended, I have mentioned, day 1 4 drugs followed by 2 drugs for 2 to 4 days. But in if multiple anti-neoplastic drugs are used, we have to continue for the prolonged period. Then breakthrough nausea and vomiting, we have to re-evaluate any other causes there for breakthrough nausea and vomiting. Then we can use olanzapine for breakthrough nausea and vomiting. Other drugs can be used in breakthrough vomiting: lorazepam, alprazolam, dopamine receptor agonist, because the lot of times breakthrough nausea will be because of fear of vomiting. That will be a very important factor, especially in chemotherapy induced. So to reduce that fear, we can use benzodiazepines and other anxiolytic drugs. This for anticipatory nausea and vomiting, there are treatment options, non-pharmacological treatment options are available. There is progressive muscle relaxation, guided imagery, hypnosis, and systemic desensitization. There are other integrative and non-pharmacological therapies, management nausea, vomiting will be there. Because why we are focusing more much of nausea, vomiting? Because this affects one is quality of life, nutrition, and also it affects the anti-chemotherapeutic agent dosage. If the patient develops severe vomiting, not responding, they have to compromise on the chemotherapeutic agents. That leads to suboptimal response to the cancer outcome. Then radiotherapy induced, it can be high, moderate, or low depending on the type and location of radiation. And usually the treatment will be simpler as compared to the chemotherapy induced. You usually have 5-HT3 receptor antagonist steroids. Then in combination, chemoradiation, concurrent chemoradiation, according to the chemotherapy related antiemetic guidelines has to be followed if it is a high or medium, moderate, low or minimal one. The potentially new antiemetics are amisulpride, mirtazapine and thalidomide. These are the drugs. Some places they are used. Then comes to the mucositis. Mucositis due to the radiation or chemotherapy. Why it is important? Because it affects the quality of life, and there is a breach in the mucosa. There is a chance of infection, twice higher chance of infection, and there is a 4 times higher chance of death because of the mucosal break. Patient will go for a severe sepsis and septic shock. Also, it causes dose reduction of the chemotherapeutic drugs, which leads to suboptimal response to the cancer treatment. It adds to the financial burden of the cancer management because the mucositis management, nutrition improvement, that takes a lot of cost. There are 5 stages of mucositis. That is initiation, primary damage response, signal amplification, ulceration, and healing. Usually we see the clinical manifestation, clinically identifiable lesion occurs in the stage 4 and 5. Before that, there will be just erythema and symptoms will be there. Identification at early stage is very important. Again, there is a grading. There is a grade 1 to 5 mucositis. The treatment will be, we have to assess the patient risk factors, and majority of the time it will be managed with the conservative management. In this mucositis, the nutrition part is very important. Our role in mucositis comes as, one is nutrition, maintaining the enteral nutrition. Sometimes we have to place a percutaneous endoscopic gastrostomy, even in some cases where there is a mucositis involving the stomach. Some studies have shown that placement of PEG, it promotes the healing involving the mucositis in the stomach. So basically our role is give a enteral access for the nutrition in the mucositis patients. That is one thing. Second, managing the complications like mucositis with developing UGA bleed or something like that, we have to manage endoscopically. Usually we have to avoid, generally what we are chlorhexidine based antiseptic we have to avoid in mucositis patients. That will worsen the situation. Normal saline goggling or benzodiazepine mouthwash, lignocaine mouthwash, these are the drugs which are effective, and we have to give the vitamin supplements that will be sufficient to heal it. If the grading is very severe, we have to admit the patient and give antibiotics and other supportive measures, and we have to withhold the chemotherapeutic drugs till the end. Thank you.
Any questions from the house? Sir.
An elaborate talk, Dr. Tribhuti. Actually, my question is on resveratrol. Does it have a role in oncology drug-induced diarrhea?
Yes, resveratrol, it is routinely used, but as far as the diarrhea in oncology patients, the loperamide works better than the resveratrol or ramosetron. All this strength, the loperamide works better.
And the second is a comment. If there is a mucositis, then collagen spray works. I've done it in 3 patients, not a big number, but it's really helped. Just spray collagen endoscopically, the mucositis starts healing. Okay. So I'd appreciate all the professors as here, Professor Ganesh is here and Professor Murli, apart from other professors. So just need their comments also on managing, because this oncology drug-induced problems, managing those are real bugbear problems, so need your inputs.
Thank you. So you spoke on vomiting and nausea with chemotherapy, radiotherapy, etc. You spoke on mucositis. There are some people who come with just loss of appetite, severe loss of appetite, unable to take. Is there any medications that you give for improving appetite?
No, sir. As of there is no such medications recommended. But for improve the nutrition, yes, we do some endoscopic measures to improve the nutrition, like PEG placement or nasogastric. As of no drugs to promote this.
What about steroids? Some people do give steroids.
So, I have seen people use steroids, but I personally have never used them to boost appetite per se. Like Dr. Tirumurthy is saying, I don't know if there's any data to support any medical management to boost appetite, sir, to be honest.
Sir, off-label, what we are using, practically using, one is the steroid, another one is pancreatic enzyme supplements. They are using it to facilitate the digestive process and improve the.
Right.
Otherwise, no papers recommending or any drug is recommended to improve that.
That was an more informative talk, because we commonly don't encounter these kind of patients unless the patient develops vomiting or a dysphagia. That is when a gastroenterologist is being commonly called for from an oncology department. Otherwise, these kind of mucositis and other things, they tend to manage by themselves with all the above said drugs like ondansetron and all these things. They usually start with, because they have a protocol as such. So our role comes in only when the patient develops the dysphagia because of severe mucositis again. That is when we are being called for. And maybe at that time, we can decide upon whether it's going to be a simple mucositis or an existing stricture following a radiotherapy and all these things. And that was more informative because we never used palonosetron. Till now, I haven't used a palonosetron as such in these kind of patients when they are asked for opinion regarding this dysphagia or persistent vomiting and other things. That's quite informative.
So
And
I guess like what Dr. Tirumurthy pointed out, palonosetron is the primary drug of choice, at least in chemo-induced nausea vomiting. Typically, that's what I think. Across the board, you'll find prescriptions. So.
yes, I think only in the specific oncology centers, they used to have this kind of a protocol. Otherwise, in general, we haven't used palonosetron as such in a routine day-to-day gastroenterology practice. And whenever we have called for on an occasion for this kind of chemotherapy-induced complications. That was an exhaustive and informative talk. Thank you very much. And another. So
right,
that is being
right.
followed in the protocol. So they used to combine with apripitant.
So
That's what.
Apripitant, apart from this chemo-induced nausea vomiting, usually it is useful in post-operative nausea vomiting. Otherwise, general in case it is not used because maybe there are not much of studies. Second, it is costly. And second is a long-acting drug. Suppose somebody is having vomiting, how long to use that drug? All those things are not there. Generally, it is chemo-induced nausea vomiting and post-operative, refractory post-operative nausea vomiting. Nutrition is the one area it is totally neglected, especially in oncology patients. Oncology patients are nutritionally affected various ways because of the malignancy itself, loss of appetite. Second, there is a mechanical obstruction, poor nutrition, all those things. So I think it is a time for the gastro, we have to get involved in improvement of the nutrition in various ways so that the oncological outcome will be better. That is one of the important reason why the oncological outcome is even now, even though it is improving, is still on the negative side because of the nutritional aspect. It is not taken care in treatment.
I think
Yes,
Sir has
couple of comments because Tirumurthy works in a cancer institute, probably is more exposed to these sort of side effects. But in a multi-speciality hospital, once the patient goes into oncology, I think he doesn't come back to us. And we probably do not see these cases, and they probably call us only when there's one situation where they have unending nausea and vomiting.
Right,
That's where
right,
we are called.
right.
So the only way we can help them is advise them hydration. And all these anti-nauseating drugs, whether it is required or not, I think as a protocol it is given before and after the chemotherapy.
As per
Apripitant and all that are probably part of the chemotherapy cycle. So
Right.
that's what I have seen in private hospitals.
Absolutely.
Private hospitals, they give a combo. They give a combo and make sure that patient is probably under.
So the pre-medication,
So it's very difficult for us to see such patients unless they are referred back to us.
right. Okay. So I think we'll go to the next talk. I'll request Dr. Murli to speak on. Dr. Murli is going to talk about another common issue that we face. We see a lot of patients with viral hepatitis who also have cancer. So I think Dr. Murli is going to talk about viral hepatitis in the oncology setting.
Thank you, sir. Good afternoon, everyone. Thanks to Dr. LBK for extending this invite. So the topic is management of viral hepatitis in patients receiving anti-cancer drugs. So quite often we receive calls from oncology people asking for incidentally detected hepatitis B or hepatitis C during the pre-op workup before chemotherapy. So what do? Let's see what the literature says. So let's start with a small pre-talk quiz. Case 1, 60 years gentleman with a CS stomach planned for chemo, and the workup showed surface antigen positivity with normal enzymes and undetectable HBV DNA. So with this information they give a call. So these are the options. What would you like to advise? Proceed with ECF and monitor the enzymes and DNA level. Start antivirals and then proceed with ECF. You just straight away say that the patient is contraindicated for chemotherapy, don't give. And start PEG interferon, try to clear the virus and then give chemo. So just keep the answers. We'll again come back to these questions at the end of the talk. The second case is 70 years lady with NHL planned for RCHOP. The pre-chemo workup showed surface antigen negativity, normal enzymes and undetectable DNA. So shall we proceed with R-CHOP and monitor the LFT? Avoid rituximab and proceed with CHOP and antivirals. Avoid rituximab and proceed with CHOP without antivirals. Test for core antibody. If positive, start antivirals, then R-CHOP. Case 3, 50 years obese lady with CA breast operated, planned for hormonal therapy. Surface antigen positivity with mildly elevated enzyme, undetectable DNA. Options: proceed with hormonal and monitor the enzymes and DNA. Start antivirals and hormone. Start antivirals and avoid hormonal therapy. Test for core antibody, same thing. If positive, give antivirals, then hormonal therapy. These are the case scenarios which we see just to stimulate our thinking. The last one, a 10-year-old boy with ALL planned for stem cell transplant. Surface antigen negative, antibody for HCV positive, normal enzyme, both DNA as well as RNA undetectable. So proceed with the transplant, monitor the enzymes, monitor the DNA and RNA levels, start antivirals for HCV and proceed with transplant. Needs further evaluation. Straight away you say it's contraindicated. So with this background, let's come to the talk. The outline of the talk will be along these lines. Let us see HPV and anti-cancer drugs. What are the various investigation strategies, treatment and monitoring methods? HCV and anti-cancer. Just a slide on HEV. Let's see commonly used anti-cancer drugs. These are the commonly used anti-cancer drugs. I just put it from the risk point of view. The lowest risk is methotrexate, azathioprine, low dose steroid. When we mean low dose, it's less than 10 milligram prednisone or equivalent, a duration of 4 weeks. And the low risk is cytotoxic chemotherapy and anti-TNF alpha with a lower potency and moderate dose steroids. And the moderate risk is anthracyclines, again higher potency TNF alpha, high dose steroids, and B cell depleting therapies, bone marrow transplant, allogenic more than the autologous, and highest risk or uncertain are certain immune checkpoint inhibitors. So HPV in cancer patient, HPV screening in all patients planned for anti-cancer drugs. It's must to do surface antigen as well as core antibody. Not surface antigen alone is not adequate. HPV DNA level, if either one of the above is positive. Anti-HBs is also preferable according to ECL and PASL. Assessment of liver fibrosis is also preferable in chronic Hep B according to PASL. So the definition is classified into two types, chronic and past HPV infection. Chronic, we have surface antigen positivity, but obviously the core antibody will be there, and anti-HBs will be negative. Past, we have surface antigen negative, core antibody will be positive. In resolve, we have anti-HBs. In isolated core, we have it will be negative for surface antibody. So let us see a few definitions. HPV reactivation. In chronic HPV, it is 2 or more log, that is 100-fold increase in HPV DNA compared to baseline. If it's previously undetectable, it is more than 3 log, that is 1000. If it's not available, then we take it as 4 log. In past HPV infection, the presence of DNA itself, detectable itself, is reactivation. And reverse seroconversion, that is from negativity to positivity, the surface antigen changes, it is a reactivation. Definition for hepatitis flare is ALT level more than 3 times, and or the value wise it is more than 100. So definition for clinical outcome. So based on these two definitions, the reactivation and hepatitis flare, HBV associated hepatitis flare is HBV reactivation plus hepatitis flare. And HPV associated liver failure is either one of the 3, the bilirubin more than 3, INR more than 1.5, or ascites or encephalopathy. and death attributed is following HPV associated liver failure. So to understand each and every word, we have to go to the previous word. There are clear-cut definitions. So the risk factors we can classify into 3 categories. It can be host, male, old, cirrhosis, diseases needing immunosuppression, virological, high DNA level, E antigen positivity. Instead of past, if it is a chronic hepatitis B, and co-infections, and also the nature and degree of immunosuppression being planned. So having seen all these things, so how will you manage HBV patient receiving anti-cancer drugs? So HBsAg and core antibody positivity testing should be performed in all persons prior to initiation of any immunosuppressive, cytotoxic or immunomodulatory therapy. And chronic HBV infection patients should initiate anti-HBV prophylaxis before immunosuppressive or cytotoxic therapy. Past HBV infection should initiate anti-HBV prophylaxis before receiving B-cell depleting therapy and stem cell transplant. Past HBV infection patient receiving cytotoxic or immunomodulatory or targeted therapy, in whom we don't straight away start anti-HBV prophylaxis, they should be monitored very carefully with the intent of on-demand therapy. So when indicated, the HBV prophylaxis should be initiated as soon as possible, ideally before or at the latest simultaneously with the onset of immunosuppression. And once started, it should be given for at least 6 months. For anti-CD20 like rituximab, it should be given for at least 12 months after therapy completion. Anti-HBV drugs with a high resistance barrier, obviously we are using only entecavir and tenofovir. For patients without prophylaxis, the DNA level should be monitored every 1 to 3 months based on the previous levels. And patients should be monitored for at least up to 12 months after cessation of anti-HBV therapy. This is a busy slide, just to make it simple. So the one on the left side is a chronic HBV infection, where you can see there are 2 categories. One is systemic anti-cancer therapy, cytotoxic immunotherapy or targeted therapy. There we start the antivirals and continue for at least 12 months. And we don't give it for hormonal therapy. So other one is the past HPV infection. Here we give only for the B-cell depleting or stem cell transplant. So these are 2 groups. So we can also see from the drugs point of view, we can classify into low risk for reactivation, moderate or high risk for reactivation. You can see it's quite simple. For chronic HPV, even a low dose corticosteroid, there is a low risk, and moderate dose will be coming under moderate risk, high dose will be coming under high risk. And cytotoxic chemotherapy, other than anthracyclines, will come under moderate risk. Anthracyclines will come under high risk. And you can see the B-cell depleting therapy and stem cell transplants, they come under high risk. And immune checkpoint inhibitors, these are the ones which are commonly used by the oncologists nowadays, they also come under high risk. For past HPV, it's just like one shift to the left. So the cytotoxic chemotherapy will come to the low risk, and high dose steroids will come to the low risk, and anthracycline will come to the moderate risk. Autologous will come under moderate risk. So only the B-cell depleting and allogenic will come under high risk. So with this, if we see, if it is a chronic, then if the viral load is high, anyway we are going to give therapy. The viral load is low, intermediate and high risk, which we seen in the previous slide, we give treatment, prophylaxis. And if it is a past, then only in the high risk, we give anti-HBV prophylaxis. So having finished the HCV, there are only few points. HCV, we can also see from other angle. What are the benefits of HCV treatment in patients with hematological malignancies? Because it also prevents long-term complications and prevention of hepatocellular carcinoma, and long-term survival is improved, and extrahepatic manifestation we should not forget. And oncologically, it allows the patient access to multiple clinical trials of chemotherapy. In some patients, it prevents HCV-associated hematological malignancies. Very select group, it can also help in cure of these things. So HCV reactivation in HCV infected patients on anti-cancer drugs. increase in HCV RNA, 1 log from baseline, and the definition for flare is same. Clinical outcome is almost same. So subgroup of HCV patient for whom directly acting antiviral is contraindicated, not much, except for few like life expectancy less than 12 months due to non-liver related conditions, and pregnant, and major drug interactions or hypersensitivity. Rest all, we try to give the anti-HCV therapy. Sometimes the literature says that the timing of the therapy, for example, when you are giving a transplant, you start quite immediate, or otherwise you can even start after 3 to 6 months. And the other group is, the one group where we should not is uncontrolled or progressive cancer. No need to give this anti-HCV. HEV, last slide. We all know that HEV is a self-limiting, but sometimes it can become chronic because of the background immunosuppression and can rapidly lead to cirrhosis. So standard serological testing may not be reliable in these settings. RNA may need to be done, and treatment may come back to good old ribavirin and peginterferon. We should also remember that patients who receive immunosuppression for hematological malignancies can have exacerbation of the hematological side effects due to ribavirin and peginterferon. So prevention is better. So let's end with the same quiz. What could be the answer for this?
Show of hands, I guess. Option 1, option 2, okay. Option 3, and option 4. Okay, great. I think the message is
Okay. So we can obviously contraindicate the chemotherapy. We cannot withhold the benefit, and peginterferon is not in place at all. And we cannot just like that give chemo because it already surface antigen positive. So we have to start antiviral and then proceed with chemo. And for the second case,
option 1, 2.
the idea is we should not withhold the benefit of chemotherapy just for hepatitis B. That is the whole idea. So as much as possible, we should allow the patient to receive the ideal chemotherapy from the cancer point of view. We should try to give the protection, and we should not overdo, we should not underdo. So here, right. So you check for the core antibody, and if positive, start antiviral, and then proceed with R-CHOP. And case 3, in one slide we saw that for hormonal, we can give without giving HPV prophylaxis. So proceed with hormonal and keep monitoring the viral load and ALT. And case 4, we have repeatedly seen that hematopoietic stem cell transplant is one of the high risk category. So what to do? Even if surface antigen is negative, we are not given the information about core antibody, so we should do core antibody and then decide. We know that as far as HCV is concerned, antibody positive and RNA negative means nothing, so we can go ahead with transplant. So the take-home messages are always screen for HPV and HCV infections in all patients with cancers, risk stratification based on the zero status and immunosuppression, monitor for a hepatitis flare and reactivation, and well-established strategies for both are available. And gastroenterologists may not be aware of all the latest oncological things, so we should be aware about the type of anti-cancer therapy. Particularly, like when preparing the slide, I read a lot about this immune checkpoint inhibitors and other things. So we should be aware of these things so that we know where we stand versus the viral infection. Thank you.
Thank you.
Dr. Murli,
I think we'll quickly
yes.
take a comment.
With the recent changing concept of treat all patients who are HPV positive by the WHO in August 2024, has that changed now for patients who are on cancer treatment?
Practically we do treat all the patients.
Without checking for any markers, HPV positive, we treat?
Yep. So if we see HPV positive, generally we give, madam. But HPV negative and core antibody positive, then it comes under past infection. So this is the literature says. But yeah, before preparing for this talk, I was also like, HBCG positive means
Treat all.
we don't take chance, because the anti-HBV drug is so simple, cost-effective, safe, we can give. But since this is a PG course, I thought let us go into the literature. So this is what the
normally we
literature
recommend
says.
the triple panel strategy, no? Get all the 3 markers done and then check out what exactly is the status of the patient. The anti-HBC total positive would be occult HBV.
Yeah, occult HBV.
And most of the times you find the DNA is also low. So the question is to treat or not to treat, and just follow
Correct,
with an ALT.
but that is the literature. But in practical, as I told, like we don't take chances. We give antiviral. But yeah, this is what is there.
Okay. Any questions from the house? One question.
Look at viral markers even for that? I mean,
Yes.
some place I saw that.
Yes. Tyrosine kinase also.
TKIs, yes.
In fact, it comes under a high risk thing.
Okay. And, I mean, though not directly related to this viral hepatitis part, but there's suppose, I mean, sometimes we get consultations after they develop a flare. And sometimes they don't get better with antivirals. So what is the take on transplant in such a setting, like if they don't improve?
That has to be individualized, because a lot of malignancies, what is the state of that malignancy? Because many times they may be having a disseminated malignancy where the transplant itself will become a contraindication. So
I think Tirumurti, you want to say something?
So, for all patients, especially for cancer patients, we have to do the HBsAg, anti-HBC total and anti-HBs titer. If possible, HPV DN also, but these 3 markers should be done for all the patients, especially for the cancer patients. Because majority of the time the patient will HBsAg negative, they start chemotherapy, they will flare up. Now they will become HBsAg positive, DNA in lax, they will come like that. That will affect their chemotherapy and this thing. So all the 3 markers has to be done. Second, the preemptive treatment, even if it is HBsAg positive, even though guideline says past infection and chronic infection, even if it is HBsAg negative, anti-HBC total positive, they are going for chemotherapy. Again, the chemotherapy drugs are classified into grade 1 to 3 depending on the risk of reactivating the virus. But in general, any kind of risk of chemotherapy drug, preemptive antiviral is given in cancer patients. Because why we are giving? Because initially they may give low risk or moderate risk of kind of chemotherapy agents. Later they may switch to another higher risk of drug that we may not come to know. Without informing them, they may start. That time the patient will develop. So any patient going for chemotherapy, either they are HBsAg positive or anti-HBC total positive, it is better to start preemptive antiviral and continue till the chemotherapy drug, that course is completed.
Okay, thank you. I think for want of time, we'll move to the next talk. So I'll invite Dr. Vadivel. He is going to speak on another common issue that we face, radiation proctopathy. It's very commonly seen. So Dr. Vadivel will discuss about the management of radiation proctopathy.
So at the outset, I would like to thank the TNISG for giving me this opportunity. So my talk is on this radiation proctitis. This is one interesting topic because so the therapeutic option is going to be very few, and we commonly use we can tend to get referred these kind of patients for a lower GI bleed, basically a bleeding PR, a painless bleeding PR apparently. And so this forms less than 1% of your common day-to-day practice, but still the history when the patient comes to you with a bleeding PR, a proper history taking is the most important thing to have a clinical diagnosis of this radiation proctitis. Because as you know, this radiation proctitis in the sense, the radiation-induced inflammation of the rectum. So whoever undergoes a pelvic irradiation tends to have a tendency to develop this kind of a radiation-induced rectal mucosal injury, basically. And with newer modified radiation techniques, the incidence has been quite low. It was rampantly seen in the yesteryears, maybe a decade ago, where there was external beam radiation therapy where the whole pelvis was irradiated, and commonly in case of CA services. And we tend to have a lot of patients with radiation proctors at the time, but of late with modified techniques of this radiation therapy, so the incidence or the prevalence even has come down a lot. So what happens during a radiation when it is given to the pelvic region or regional malignancies? So it has become an integral part of any cancer treatment because with these advancements, and it tends to develop after a radiation therapy regime for pelvic malignancies. It is either given as a neoadjuvant therapy or an adjuvant therapy. But it has got a variable presentation because each and every individual varies, each and every individual susceptibility for this radiation-induced injury varies, and the severity also varies according to each and every individuals. And why is that we don't commonly see this? Is mostly it is self-limiting. So depending on the dose of radiation, the duration of radiation, and the pre-existing factors. So there are various entities why that every individual who undergoes radiation doesn't develop radiation-induced injury to the rectal mucosa. So we can see a lot of factors play a role, like age, the form of the radiation that is being given, the route of administration of various drugs, and the dosage of the drugs, and the targeted organ, how precise the targeting of this radiation to that particular organ like a prostate or a cervix or even a rectal malignancies. And a lower BMI predispose these individuals to develop radiation-induced mucosal damage, and coexisting malnutrition, and coexisting other diseases, systemic diseases, like which can narrow down the vessels supplying that part of the rectum, like a diabetes or a cardiovascular event like atherosclerosis or any vasculitis event, which can compromise on the blood supply to that particular tissue, predominantly the rectum, and even the collagen vascular disease wherein the vessel wall is not well formed, and previous abdominal surgeries wherein it doesn't allow the other motile or the mobile part of the intestine to move out of the pelvis, which gets which retains the mobile part of the intestine into the pelvis because of formation of adhesions, and concurrent use of chemotherapy. All these things play a role in contributing to an individual to be susceptible for a radiation-induced mucosal injury. So how is this injury happening? So what we have in radiation is the high energy rays, which restricts the growth of rapidly dividing cells predominantly, and it causes the damage at the level of DNA, so wherein it affects the lipid and the protein core, thereby inducing apoptosis and cell death. And this injury is predominantly seen in the proximity to the target organs or a fixed anatomy in the pelvis. The common fixed anatomy in the pelvis is going to be the rectum. That is why the rectum is commonly affected. Whatever structure is being there inside the rectum, even the small bowel, when it gets stuck, can get injured, but the susceptibility of this small intestine is going to be less than that of the rectum. And almost 75% of conventional pelvic radiation therapy eventually suffer from radiation proctitis. That is a conventional pelvic radiation, not a modified one. The damage to the rectal epithelium varies. It varies from the superficial mucosal injury to transmural injury here. So when it develops a fibrosis and obliterative sclerosis of the vessels, then it develops a full thickness injury. Then we call it as a chronic radiation proctitis, which is what is commonly seen for further management. So radiation exposure leads on to mucosal injury, and even it can cause endothelial dysfunction, which can progress towards a chronic radiation injury. Otherwise, it is commonly self-limited if it is going to be confined to the superficial mucosa, and leading on to fibrosis, and which in turn leads on to further ischemia of the normal cells, which can predispose these individuals for development of radiation proctitis as such. That is predominantly the formation of the neovascularization vessels like the telangiectasias. So as I said, it can be an acute. That means up to the period of 3 months following a radiation therapy, we call it as an acute. And in this period, these individuals tends to present with or tend to have a injury to the superficial mucosa, so which leads on to urgency because your rectal compliance is lost here. So these individuals tend to have a rectal urgency because of loss of compliance of the rectal mucosa. And this can present with mucus discharge per rectum, so without even any other symptom, or if it is going to be severe enough, these patients can have diarrhea or cramps or even bleeding per rectum. But this is commonly self-limiting. With the interruption of the radiation and chemotherapy, these patients tend to go in for remission. They get devoid of symptoms. Whereas in chronic radiation proctitis, so it is occurring when it occurs it can occur for months to years later, even after completion of the radiation therapy, even 5 to 10 years later it can develop. So it commonly presents with rectal bleeding or a refractory discomfort, and in very varied cases we can even see strictures on even perforations. So why this kind of a chronic injury is happening is because of the compromise on the blood supply, because of the obliterative endarteritis which happens, which in turn leads on to chronic fibrosis. So evaluation, a proper clinical history and a proper clinical examination. The rectal examination also plays a big role in order to rule out any rectal malignancies as such. And we seldom use this fecal calprotectin and lactoferrin in these kind of cases because the patient presents you with a discomfort. You examine, you feel the fresh, you just examine, and then your rectal examination shows fresh blood in your finger stain, and which can be confirmed by means of endoscopic evaluation, wherein you can see a friable mucosa, a bleeding spot, or an ulceration, or commonly the typical picture of a chronic radiation proctitis is going to be the telangiectasias because it is because of the thinning of the mucosa, wherein it exposes the underlying vessels, which is arborizing because of the chronic hypoxia induced neovascularization, presenting as a telangiectasia. And they tend to have a pale mucosa and at times ulceration. With the tortuous blood vessels, as I said, it's going to appear as a telangiectasia and fibrosis, which we call it as a chronic radiation proctitis. So we got varied grading of this thing, radiation proctitis. 0 means no symptoms. So mild diarrhea, mild cramping, bowel movements of 5 times daily, or slight rectal discharge, we call it as grade 1. Grade 2, moderate diarrhea, which presents with more than 5 times a day of bowel frequency, or excessive mucus or rectal mucus or bleeding as such. And grade 3, we call it as obstruction or bleeding requiring surgery. That is because of fibrosis or stricture formation, and very rarely necrosis and perforation or fistula formation even because of the radiation therapy. So how to manage it? So acute radiation proctitis, symptomatic therapy, adequate amount of hydration so that the patient don't get dehydrated. At times we need to use steroid enemas and antidiarrheal medications, more of symptomatic care. Okay. Next comes the other modalities like the formalin therapy. So what we use commonly is going with the 10 times diluted formalin. The formalin commonly comes with 40%. We tend to dilute it to 4%. So 40% has to be made as 4%, and which can be applied in that particular part where the bleed occurs, like as it of a soap gauze or an endoscopic directed visualization, and application of this formalin over the bleeding spot as such, or the telangiectasic vessels. So even formalin, 2% formalin has been found to be effective in these kind of management. Steroids, it has since the steroid has been proposed as to be having a anti-inflammatory action and also stabilization of membranes, and it is commonly used with metronidazole. And other anti-inflammatory drugs like sulfasalazine by means of 5-ASA, it has a tendency to inhibit the prostaglandin synthesis, thereby reducing the inflammatory pathology in the locoregional part of the rectum. So sucralfate enema, this is commonly available nowadays. We can use this 15 ml in diluted in 30 ml of water, so that it constitutes around 45 to 50 ml, so that it doesn't cause much of a rectal discomfort, because your rectal compliance of up to 50 ml is quite normal. So these can be used commonly. It forms a protective epithelial barrier. It also has got an angiogenic action, so that the underlying hypoxic ischemia can be partly mitigated by means of angiogenic action, thereby it increases the local blood flow and exert an cytoprotective action. Short chain fatty acid enemas, these have been on trials. We don't commonly use it nowadays. And the most important thing is going to be the organ plasma coagulation. So we predominantly use this thing, or these kind of patients get referred to us for a bleeding PR, where we go in, see there are multiple telangiectasias with a thinning out of the mucosa up to the level of rectosigmoid or just beyond the rectosigmoid even. And we tend to use this as a coagulation protocol. So we tend to ablate with the argon laser. So we tend to use it as a coagulation protocol because the argon gas, which is an inert gas, becomes ionized when it comes in contact with the current. And then commonly we use a wattage of 40 with a flow rate of 0.6 to 2 liters, depending on the intensity wherein you need. And the most important drawback of using this kind of organ plasma is going to be the abdominal distension if you're going to use it for a longer time. So you need to intermittently decompress the rectum as such. And if you're going to hitch it over the mucosal surface, it's basically a non-contact method. If you're going to hitch it over the mucosal surface, it can cause deeper burns and can cause ulceration or even perforation at times. So there is another laser which can be used like yttrium YAG, but it causes a deeper tissue injury, so it's never used because it has a high tendency to cause deeper tissue burn, necrosis, stenosis, and fistula formation. So very rarely, in resistant cases, we can go for a hyperbaric oxygen therapy. That is nothing but a chamber with a pressure more than that of atmospheric pressure. Again, this concept is going to be the neovascularization collagen formation in order to promote healing. The duration of treatment protocol is going to be for 1 to 2 hours. So it's considered predominantly in refractory radiation proctitis. And very last, refractory symptoms hampering the quality of life, you can go for a surgical procedure, like not to remove the involved part, but to divert the stools from that part, so that we are going to rest the rectum. So wherein we can go for a fecal diversion ostomy. So superior results have been shown to be with transverse colostomy over that of the loop colostomy. So no resection anastomose of the damaged tissue over here. So as such, then clinical presentation, assess the duration of symptoms, whether it's going to be acute or chronic. Acute, mostly self-limiting. So stop the radiotherapy for some time, so give time for the tissue to heal, then manage symptomatically with hydration and antibiotics if needed. Chronic, exclusion of other causes of the bleeding PR like any internal malignancies and other things. Then if it's going to be mild enough, go for a loperamide, steroids or anti-inflammatory agents, or even sucralfate, or even go for a case of bleed, you can go for a formalin therapy or sulfasalazine, sucralfate, or argon plasma coagulation with or without oral antibiotics. So take home message, it should be clinically assessed after, all patients should be clinically assessed after radiation therapy. The patient's age, associated comorbidities, performance status, the severity of proctitis, the patient's expectations are some important factors to be considered while planning for a treatment for this radiation proctitis. So at the end, a multidisciplinary approach before finalizing the treatment protocol has to be approached. Thank you.
Dr. Vadivel, nice presentation. So I just wanted to share my experience. 30 years or more, we've been using this formalin gauze. I don't know how many of them use formalin gauze. Yeah, quite a few. We still tend to use because sometimes the argon plasma and all that doesn't work that effectively. GV is there. GV, what do you think for radiation proctitis? What would be the best modality? Does holmium laser work? Because we don't use neodymium or yttrium.
Yeah, very rightly said. Actually, this actually holmium laser and all actually they are not very commonly used in clinical practice. I think as rightly said, actually hydrogen peroxide does work actually, and of late we started using other like sucralfate enemas and all. Actually, these are the other things that can be used actually, and maybe can add some steroids to it. Actually, maybe that helps to alleviate the symptoms in this patient.
One another thing that helps is collagen spray. Even in your hyperbaric chamber, you said collagenization helps in the healing. This is what we found, and I think it was CMC Vellore was saying these angiectasias have this unfolded von Willebrand factor. You spray collagen, it just absorbs it, adsorbs it, and then starts shrinking down. So we have seen a very good response with collagen spray as an acute rescue measure. If there is a active ooze in radiation proctitis, we have used. So, but many of these cases are chronic and keeps recurring for quite some time. I've seen it even after years, recurrences.
See, we even had a study in MMC when I was doing my postgraduate days there. So in patients who present with torrential bleed, wherein we will not be even able to see where the bleed is coming from. So what we did was, we used this 4% formalin therapy. We took it in a 50 ml syringe, 5 ml to be diluted to 50 ml. So that is enough for the rectal compliance part even. It doesn't cause too much of discomfort. What we did was, we placed a Foley's catheter beyond the rectosigmoid junction, inflated it, then gave a traction and clamped it. And we put a second Foley's catheter just beyond the anal verge, asked the patient to retain it, inflated the balloon, asked them to retain it. Then through the distal end, we infused this 50 ml of 4% formalin in the left lateral posture, and then we made them to refrain from pushing out the distal tube. So that has to be done only in conscious patients. It cannot be done in unconscious patients because your rectum tends to push out the distal balloon. So thereby, once we did these kind of things, so within the first 20-30 minutes, the patient tends to experience a severe burning sensation. The very next day, the patient becomes completely symptom-free without any bleed. So we had it done in some 10 to 15 patients during my postgraduate day. We had it as a paper as such.
But those of the juniors who want to try, you'll have to put a lot of Vaseline for the anorectal junction. Otherwise, patients would really cry of burning pain.
Yeah.
Because formalin will really burn the tissue.
Yes.
So I used to use rigid sigmoidoscope and then use the formalin, gauze soaked in 2% formalin, pack it for 20 minutes, and then pull it out.
Yeah. Thank you.
I think this is the only complication of chemo, radio, which is referred to us. Most of the others are treated only by the oncologists, including antivirals they themselves give. But now I think it's renamed as chronic radiation proctopathy and not proctitis. And sucralfate seems to be good. This is my experience. I think sucralfate, any mass of 3 to 4 grams every day for about 4 to 5 weeks seems to help. And it has really helped in my case. But just a question to you, how does the latest radiation methods like proton therapy and SPRT, do they induce this amount of radiation proctitis, or are they better than the conventional radiation?
So they're definitely better, but the issue is, of course, the cost for the radiation therapy. So I don't think a lot of patients are able to afford a lot of these advanced therapies. I mean, if you ask Proton, at the end of the day, I don't know how much Apollo charges. We have a Proton now, and I can tell you I cannot afford it today. So I can tell you this for a fact. So it's difficult. So I'm sure these complications will happen, especially common with not just cervical cancers, especially a large number of prostate cancers also being detected. Prostate also receives a lot of radiation. So clearly, these are the two common organs, cervix and prostate, where you'll find these going up. And radiation is the first line therapy for both of these. So clearly,
I think nowadays the AA plays a major role in controlling the amount of radiation where it has to be given, until what depth of radiation has to be given. So we have got some softwares which modulates or modifies the dose of radiation as such, so that doesn't penetrate deeper to cause rectal injury as such for a prostate. Definitely, yes. Image modulated radiation therapy is there.
I wanted to share my experience with radiation proctopathy, which we have been for many, many years. As Mohan Prasad said, we initially gave formalin. In fact, we used to do sigmoidoscopies and then touch each of these areas, and we had some success rate. And we had one person who went up to Singapore University and came back, and they were doing it very frequently. But it was not comfortable. Again, a lot of pain if it comes at the anal area. Second thing that came in was these two things, sucralfate and APC. Before that, we tried mesalamine, we tried sulfasalazine, we tried steroid enemas. None of them work. Actually, none of them work. The two things that work now are, I think, APC and sucralfate enemas. Problem with APC is that there is some result, but there is most often a recurrence after some time. So I feel there is no good treatment at present. And I was just thinking in my mind as you're speaking, we give for abnormal blood vessels, we give thalidomide, we give this an RFA to. So, but these are ischemic things. So whatever we do, it may make things worse. So I think this is a good area where something can be done to improve the life of all these people, especially cervical cancer, prostatic cancer, these patients.
I think there are two other modalities available. Ferrochrelium is one thing that is available, but there is no evidence to show that. The other thing is tranexamic acid is also available as a spray right now. These are very good topical agents which very minimal side effects right now.
do you use this formalin therapy as a last resort when the bleed hasn't settled down?
So I think we'll move quickly to the case-based discussions. So, thank you. Right. Okay, thank you. Right, thank you. So this is just going to be, some cases on some GI cancers that are commonly referred to us as gastroenterologists, and I've tried to make it interactive. So there are some rules to the game. Clearly, these are case scenarios with questions. Active participation is kind of expected, so I hope there will be some active participation from your end. Raise your hands to participate in any question that I ask. Feel free to stop and ask questions in between. And unfortunately, the sponsors did not give me the right to give prizes to people who get the right answer. So I think the secretary, you can, if you want prizes, you can take it up with the secretary of TNISG, and I think he will do the needful. Okay, so coming to case 1, 75-year-old male, otherwise good performance status, grade 2 dysphagia, no cough, regurgitation or chest pain. On upper endoscopy, there is a growth from 23 to 29 centimeter. The scope was negotiated with significant difficulty. The biopsy shows a moderately differentiated squamous cell cancer, and a CT was also done, which shows some thickening in the esophagus with multiple liver mets. So what should be your next plan? So should it be esophageal stent followed by palliative chemotherapy, radiation followed by palliative chemotherapy alone, or best supportive care only? So take us for option one. Okay, so quite a few takers. Option 2. Okay, some takers again. Option 3. Okay, no takers for chemotherapy and best supportive care only. Option 4. Okay, so the right choice would be option 2. Okay, radiation with palliative chemotherapy. I have a very esteemed panel who gave 3 talks now, so I'm going to ask them some questions. Right. So I'm coming to that, sir. So I mean, if Dr. Vadivel, you can take this. Why choose? How do you make the choice, stent or radiation for patients who are dysphagia, with an advanced esophageal cancer?
Yeah. So this patient has been diagnosed to have a squamous cell carcinoma. So the dictum is that these kind of squamous cell carcinomas who presents with the dysphagia melts with radiation therapy, so that once the patient is put on radiation therapy, his dysphagia would resolve. That is one thing. The next thing is it can form a stricture. So that is when maybe our expertise may be needed in these individuals to put a SEMS or go on for a dilatation as such.
Right. So there is data to say that radiation gives more durable relief for dysphagia and also pain if the patient is having any. What are the absolute indications? Where would you actually put a stent? I mean, if a patient is coming to you, what are the situations where you would say, yes, I want to put a stent for this patient?
Yeah, when the patient is not going to be fit enough to undergo any further form of therapy in the form of chemotherapy or radiotherapy, who can be put upon, then definitely the mitigation of dysphagia is the most palliative thing what we can offer to him. That is, the joy of eating can be restored for these individuals.
Right.
So this is the immediate definite indication for the patient. Apart from that, the progression of the disease, like when it infiltrates other organs, or it forms a fistula, or it undergoes a perforation, the tumor tends to perforate through and through.
Right.
All these things, these are the indications where we need to go for a fully covered SEMS. There is no point in putting an uncovered SEMS in these individuals. Any abnormal tract formation has to be managed with putting up a fully covered SEMS with fixation with the clips.
Okay, so I'll just come to the practical considerations now. So whenever you have a patient who's coming to you with dysphagia, there are some, of course, important patient factors that you're looking at. Of course, the indication, like I think Dr. Vadivel pointed out to, the location and the length of the tumor. Often if you have cervical tumors, it's often difficult to stent. And these are the patients where, you know, putting a stent is technically challenging. One may not yield the best results. So performance status and of course overall survival is another thing that you're always looking at. And in some patients, especially if you have a large bulky mass that is somehow compressing or abutting the bronchus, it's best to get a bronchoscopy prior to see if there is any narrowing in the airway. Because sometimes you may put a stent and the patient may incidentally go into may have a stridor subsequently, and you will have to send him immediately to a pulmonologist who will have to put a tracheal or a, you know, bronchial stent. So these are situations that, you know, you should always be careful, have a good imaging prior, review the imaging well, and then take a call. Of course, what are the stent related things that you look at? Of course, like Dr. Vadivel said, partially covered. We don't have uncovered stents anymore, so we either use a partially covered or a fully covered stent. Again, the choice, you have some stents which are distal release, some stents which are proximal release. So distal release stents, typically if you have anything in the mid or lower esophagus, distal release stents are very, very easy. So they deploy from the distal end. Once you're past the stent, the distal end opens first. On the other hand, if you have very little space, you know, at the upper end, let's say you have, let's say, 2 or 3 centimeters at the upper end and you want to place a stent, a proximal release stent is often something that you will choose, because that way you have better control of the proximal end rather than the distal end. Then again, of course, in patients where, you know, the tumor, you have a fistula, but it's the tumor is not leading to a very significant narrowing, you can put something called a large flare stents. They are also available in the market. And of course, there is a lot of people who would say anti-reflux stents can be used for putting them across the GE junction, but then again, data doesn't support their use. So if you're asking me if there's data to say anti-reflux is better than standard for GE junction, absolutely not. There is no data at the moment. What about dietary advice? And last thing, most importantly, after the stent, make sure that you give them a very good dietary advice. There's something called a prosthetic diet. You can find it online. Typically, you avoid fiber, you know, dense foods, which will eventually get stuck in the stent and lead to obstruction. Then again, you know, patients often, I often recommend patients to have a small amount of Coke or Thumbs Up or something after the meal. It often helps clear the stent, and the patients are also happy, of course. You know, you get to have a cold drink at the end of the meal. So clearly, it's something that is easy to do. Coming to case 2, okay, 45-year-old male, chronic tobacco chewer, evaluated for dyspepsia. On upper endoscopy, there were 2 lesions. One was like a one was a slightly raised lesion, the one that you can see at the bottom, around 2 centimeters in length, and another one in the distal esophagus, very flat lesion, very difficult to identify, but we were able to find it. So question is, what information will image-enhanced endoscopy add in this particular patient? Does it lead to margin assessment alone? Does it lead to early to establish the diagnosis of cancer? Can it give depth assessment, or will it give all of the above? I mean, margin, yes or no? Okay. Okay. Diagnosis establishment? Okay, yes. And again, depth assessment, this is esophageal. So yeah, depth assessment, yes. For esophageal and colonic tumors, image-enhanced endoscopy is useful to assess depth. In gastric cancers, in Barrett's, no. So Barrett and gastric cancers, depth assessment cannot be done. In esophageal and in colonic cancers, your NBI can be used to assess depth as well. So the answer is all of the above. So coming to Dr. Tirumurthy, he works in a cancer center. He often sees, oh, please, sir. Okay, so there are 2-3 reasons here. One, the pattern of appearance. One, I think I'm coming to some findings that I'll point to later. So I'll maybe elaborate over the next few slides. Okay, Dr. Tirumurthy, you often pick up early esophageal cancer. I think you have one of the largest series from South India on esophageal ESD. So I mean, can you tell us how do you pick them up?
Majority of esophageal cancer, what we are doing is mainly we pick up the cases in the surveillance endoscopies. Those who are coming with the head and neck cancers, they come for surveillance endoscopy almost yearly. In those patients, because the risk factor is the same, common risk factor for head and neck cancer and esophageal cancer. So in that, we pick up the early esophageal cancer. That needs, one is high index of suspicion is required. And we have to usually, when you are planning to do early cancer detection, patient has to be, the endoscopy has to be done under sedation, and adequate preparation has to be done. And you have to spend time. You have to be very patient, and you have to carefully, you have to check each and every part of the esophagus or the stomach. And we have to use the black hood. In the endoscope, we have to use the black hood for the better this thing. We have to minimize the injury to the mucosa. Then only we cannot miss, otherwise it will overestimate the finding. Somebody will overestimate. That is how high index of suspicion, careful examination, and doing it under sedation. All this will enhance the early cancer detection, whether it is esophagus or stomach.
Right. So typically, I mean, if you're, sir.
In squamous cell carcinoma, if it is in the esophageal, if it is involving the submucosa layer 3, SM3, then the chances of, already lymph nodes, loco-regional lymph nodes being involved is very high.
Right.
So that'll be one indication for EUS.
Yes.
Not, I mean, just from NBA alone, in that situation, we might be tricked.
So SM3 would mean deep submucosal invasion. So typically your NBI appearance itself will typically point to having a higher grade in those patients. So I'll just come to both the NBI findings. So important is, I mean, for you to remember that whenever you're reporting early cancers, you often use something called the Paris classification. It is something that is a standard. Please learn this and always report using this classification whenever you're seeing an early lesion. Let it be in the colon, let it be in the stomach, let it be in the esophagus. This is the classification that has to be used. Standard reporting guidelines would recommend this to be used. Now, importance is that it not just indicates morphology of the lesion that you're finding. In some areas, it also reflects depth. So in the esophagus, if the morphology is very flat, that typically means that it has not gotten deep. But anything slightly raised or slightly depressed means that there is deeper invasion. So in esophageal lesions, if it's very flat, typically may be endoscopically resectable, but anything deeper or higher may not be. So we typically use something called dye-based chromoendoscopy first, and we use Lugol's iodine in the esophagus. Now this was the same patient. This is the lower lesion. You can find this highlighting, on the Lugol's. And there's something called the tatami sign. That's like a mat. You can see the matting in between the lesion. That means that there is no deep invasion. And again, this is another lesion where there is no tatami sign, so there may be deeper invasion. So it's a very good modality to use, but clearly NBI has superseded this. So we often use something called the JES classification now. Remember the names, you cannot mix up the names. So JES is for esophagus. So JES classification, again, you go from A, B1, B2, B3. What you look for is dilatation, tortuosity, change in caliber and varying shapes of something called the IPCL, intrapapillary capillary loop pattern. This is what the IPCL is. This is a normal pattern. This is loops that are formed. So this is the B1 pattern. And you can also see on Lugol's there's something called a pink color sign. So this is B1. This is the slightly raised lesion. Again, this is B2. Slightly, the loops start opening up. So it becomes, from a pinhead, it becomes straighter vessels. And again, when you have deeper invasion, you will have a bigger lesion and you will have bigger vessels. So clearly, the IPCL from a loop will straighten out and become bigger. So it's as simple as that. So this was a T2 lesion. So clearly, in the next steps, whenever you have an early lesion, you do appropriate imaging, have an MDT discussion. If you're planning for an endoscopic resection, you have to do it en bloc and have a good pathologic assessment. Coming to case 3. I'm moving from esophagus. It's a 45-year-old female, ECOG 2, upper abdominal pain and weight loss since 3 months, occasional vomiting of undigested foods, once in 2 days since 1 month. The upper endoscopy shows a large ulceroproliferative growth at the antropyloric region. The CT shows a bulky antropyloric mass. You can see the mass here without any distant metastasis. What should be the next step? Option 1, enteral stent and chemotherapy. Upfront surgery followed by a histopathologic assessment, staging laparoscopy with a PCI and a neoadjuvant chemotherapy, or chemoradiation alone. Option 1, any takers? Option 2? Okay. Option 3? Okay. And option 4, any takers? Okay, so the correct would be doing a staging lab, looking at the PCI, and again going for a neoadjuvant chemoradiation. So if you look at the NCCN guidelines, even they recommend a post laparoscopy staging. That is what is recommended as part of standard for gastric cancer. Anything T2 and above ideally has to undergo staging laparoscopy preferable to do a neoadjuvant chemoradiation. Now, why we do that is because it helps to improve outcomes in this patient. Now, another important question that we often have in these patients is, what happens if these patients present with bleeding? What do you do, Dr. Murli?
Yeah, these bleed are quite refractory to normal endoscopic therapies like mechanical or injection. So normally we should go ahead with hemostatic radiation. Sometimes if there is acute bleed, we can try with IR, intervention radiology.
Right.
In IR, if we are able to see acute bleed contrast coming out, then we can do. Otherwise, if it is a chronic bleed, many of the times indolent bleed, then that may not work. And surgery should be kept as a really last option, because it's anyway a patient who's
yeah, but do you think upfront surgery can be done in a bleeding patient?
It depends. In a case
so what
scenario.
patients can be operated upfront? Clearly,
if there's no option, and because you would always like to keep the surgery as a last option in these patients. So
I think Dr. GV is getting up.
Laparoscopy, I think, is slightly over-exaggerated. Actually, majority of this, even the cancer centers, I don't think they follow because of lack of theatre time. Actually.
Right. I agree.
Though you have this thing, but staging laparoscopy is not done in majority of the centers, actually.
So at least as a protocol.
As a protocol, yes, but I think that I don't know whether that is a message that has to be passed on. But no center practices staging laparoscopy, neoadjuvant therapy followed by surgery.
Right. Maybe go ahead with neoadjuvant therapy upfront instead of doing the staging lap. That is what is done most often. But the ideal situation would be doing a staging lap and then going. Okay. Thank you. Dr. Tirumurthy, again, tips for early cancer detection, early GI, gastric cancer, often something that we don't see.
This detecting early cancer, gastric cancer is usually screening the stomach is relatively difficult because larger surface, larger organ, and because of vigorous peristalsis. So here we have to be more patient than screening the esophagus.
Right.
So first we have to, it will have a lot of mucus and saliva that has to be cleared using the nasal cyst in Tnisgcon. Then again same with under sedation, go with a black hood, and we have to screen very carefully region by region. For that they have some guidelines. We have to screen for along lesser curvature, greater curvature, anterior wall, posterior wall, like that. The proximal body, distal body, antrum and incisura. Total we have to 20 to 26 images we have to take. And each places we have to freeze the image, then we have to examine. Because of the peristalsis, sometimes we may miss the lesion. Suppose we are suspecting something, you freeze the lesion and examine that particular area and document it.
Right. So I think we all know that we use a VS classification. I'm not going into details, but again, JES is for esophagus, VS is for stomach. And again, this is the important classification. This is what we standard use for early gastric cancer. And there are, of course, variations. And there's something called the MESDA-G algorithm, which is the magnification endoscopy simplified diagnostic algorithm for gastric cancer. Basically, you look at a demarcation line, and if you have a demarcation line, you interrogate that lesion, and you interrogate with NBI, look for changes in the microvascular and microsurface pattern, and if there are if there's present, then based on that, you can be able to diagnose gastric cancer. Coming to case 4, okay, this is again a patient referred only last week. So 55-year-old male, he was a pediatric surgeon, presented with constipation since 2 months, weight loss of around 8 kgs in the last 2 to 3 months, passing flatus but not passing stools since 2 to 3, I think I missed the word stools. The CT shows a mass lesion in the distal sigmoid colon without any distant mets, and the colonoscopy shows an obstructing growth at 20 centimeters. Okay, what should be the next plan? Medical management alone, colonic stent followed by stage surgery, divergent stoma alone, or upfront surgery for the primary? Okay, option 1. Okay, option 2. Any takers? Okay, option 3 and option 4. Okay, quite a few.
Actually, there is no indication for a stent in current day practice because inability to pass the scope does not mean the patient is obstructed.
Right. Symptomatically, in this patient.
No, but this patient does not pass stools.
3 days.
They didn't say for how long.
But no, SEMS, I don't think actually upfront surgery would be. See, right now we have a lot of data that you can take that unprepared colons can be taken for surgery directly without preparation, which have got equivalent results. So an obstructed lesion is not a contraindication for surgery.
Okay. Would you do a diversion ileostomy or
That could be, I mean, that could be a decision on table depending on the status.
Right. Otherwise, what are the chances of unprepared bowel and
no, there are a lot of data to show that prepared bowel, unprepared bowel, the data is the same. Results are the same.
Okay, so the thing that we did, what our surgeon chose was colonic stent, and he underwent surgery like just yesterday. But nevertheless.
Yeah, because I mean, one thing it caused the increased incidence of perforation following colonic stent with upstages of the disease actually. Okay. And inability to pass the scope does not mean that the lumen is completely obstructed.
So does your indication for a stenting in these kind of individuals, depending on the proximal dilated colon, is there any specific diameter beyond which you would advise them to go for a upfront stenting followed by surgery, depending on the proximal dilated colon? Because once there is an obstruction, if it's going to be grossly dilated,
I mean, at the most, you
the
can
surgery
do a
becomes more
Hartman's
difficult.
procedure in these patients. Actually, it is not necessary to do the thing because primary resection followed by Hartman's procedure would be the right option.
So the reason why stent over surgery, what we at least we've been practicing over the last 2 years and we've done over 70 cases was stoma. The need for a stoma, like you're saying, the need for a Hartman's has significantly reduced after putting the stent. So I think that the data from the CREST trial, the ESCO trial, and so on and so forth has also supported a very similar thing. Although, like you very clearly pointed out, it's associated with similar oncologic outcomes and the surgical morbidity and complication rate is similar. So,
No. I just want to make a comment on colonic perforation. In my practice, I have never come across a colonic perforation for a patient with a stent. I'm telling you the truth. But I do agree with you that it is, if the scope is not passing, that does not mean the patient is obstructed.
Right.
And I have done in most of these cases, even if the scope is not passing, I will actually send the patient for surgery. But I look at the patient's condition. Patient is so bad, patient is so morbid. In those patients, I would prefer to put a stent. So if I get 100 cases of so-called obstructed patients, majority will go for surgery straight away. And only a few I will put the stent. But that is mostly decided by the general condition of the patient. It is not just for the criticality of the obstruction.
Right. At least in the colon, there's no data to suggest neoadjuvant chemo-RT, but if it's a rectum, maybe yes.
It's more of sigmoid colon.
This is colonic. Okay, coming to case 5. Again, 56-year-old female, occasional bleeding PR since 3 to 4 months. A soft polypoidal mass starting at 6 centimeter, upper extent could not be assessed. On colonoscopy, it was a LST, laterally spreading tumor of around 9 centimeter size. The biopsy was a tubulovillous adenoma with high-grade dysplasia. MRI, again, early stage, no nodes. What should be your next plan? Upfront, low anterior dissection 1, 2 piecemeal EMR, 3 ESD, 4 chemoradiation. Take us for 1. Okay, take us for 2. Okay, 2 piecemeal EMR. Okay, take us for 3. Quite a few. Okay, and take us for 4 chemoradiation. Okay. So yeah, we also did an ESD, but yeah, in settings where ESD is not feasible, I mean, let's be honest, surgical options are very good, and I think that can be done. So I think, Dr. Vadivel, how do you determine the type and depth of a polyp? Again, I can elaborate?
Yeah, so it basically we need to describe the lesion first with a NBI if possible, always. So since this lesion what was projected was more of a sigmoid lesion, I think we need to go for the Janet classification over here.
Right.
And then depending on the type 2A or type 3, type 2B up to type 2B, we can still go ahead and do a ESD here. Type 3 is left for surgery, basically.
Right. So again, like I said, JNET is for colon, JES for esophagus, VS for stomach, JNET for colon. Do not mix when you're reporting. So JNET cannot be applied in gastric cancer, again. Or if you find a gastric polyp, you cannot report JNET on that polyp. So JNET is for colon. Again, The problem is 2A and 3 are very easily identifiable, but 2B there's a lot of ambiguity, and here is where you often err, and which is why sometimes you may need additional chromoendoscopy examination, and if you feel that the lesion is on the higher, is likely to fall on the side of 3, preferable to send it for surgery rather than do an ESD. So again, why in this patient ESD? And why not piecemeal EMR? I think there were some people who said piecemeal EMR can be done. Now, if this were colon, yes, piecemeal EMR can be done, but in rectum, there's a high risk of covert cancer, and which is why it's always preferable to do an en-bloc resection, and which is why I think the ESG guidelines also recommend doing an ESD or an en-bloc EMR. So I think we'll move to pancreaticobiliary, case 6. 67-year-old male, recently diagnosed diabetic, jaundice in 15 to 20 days, no abdominal pain, bilirubin of 10.8, CA19.9, 112, nutritionally well. CCT shows a dilated intrahepatic biliary radicals with an uncinate mass of around 2 centimeters in size. So it's a very small mass you can see here in the uncinate. What should be your next plan? ERCP and plastic stent. Any takers? ERCP and metal stent. Any takers? Upfront surgery? Okay. And chemo radiation first? Okay, so clearly upfront surgery. Okay. Dr. Murli, if you can take this, what do you think are the indications for preoperative drainage?
The patient is having a cholangitis, or we can't do a surgery immediately for any other reason, then we do drainage. Otherwise, soft indication is around 12 to 15 milligram bilirubin. Otherwise, straight away going ahead with surgery.
Right. I'll just ask Dr. GV, does this 15 really hold? Because I have not seen people, I've seen people operate at 20, 22, 25 also.
Absolutely no. I mean, it's an individual center related decision actually.
Right. So clearly, if you have any kind of optimization needed prior to surgery, and wait time is significant, neoadjuvant therapy is required, you do stent, but otherwise you do not, you send for surgery if the lesion is operable. What about this patient? This is again a 56-year-old male diabetic, pain in the upper abdomen since 1 month, jaundice since 1 month, weight loss of around 6 kgs, no fever, bilirubin is 18, CA19 is 1400, CT shows a 4.5 centimeter mass in the head of pancreas, short segment encasement of the SMV portal vein, abutting the CHA at origin of GDA with IHBR dilatation and CBD dilatation. What should be the next step? ERCP and plastic stent followed by surgery. Any takers? ERCP and short metal stent followed by surgery. Okay. EUS biopsy and ERCP and short stents followed by neoadjuvant therapy. Any takers? Han? Okay. And ERCP and short stems with neoadjuvant therapy. You don't need to do the EUS in this patient. Option 4. Okay. Since you are sending for neoadjuvant therapy, you need to biopsy. Now, why are we sending for neoadjuvant therapy? We need to really understand that. I think Dr. Tirumurthy, you do a lot of these procedures. Can you tell us how do you decide resectability in these patients?
Resectability is based on the vessel involvement, like superior mesenteric vein, the superior mesenteric artery and gastroduodenal artery, whether it is abutting or it is encasing, how much it is abutting. Based on that, it is a resectable, borderline, or we can say unresectable. Right. Based on that, if it is a borderline or unresectable, they will go for neoadjuvant, then followed by, once they fit for surgery, then we'll take up for surgery.
Right. So, huh? No, GDA is not, sir. GDA is not. So, the important thing, there are some red flags in this. Can someone tell me what the red flags in this patient were? Apart from, of course, the vessel involvement. I mean, other red flags. Let's say there was no vessel involvement. Will I still decide erring on the side of sending for neoadjuvant therapy?
The CA99 is...
Okay, CA99 was very high one. Yeah, the size. The size is another major criteria. If you have lesions more than 3 centimeter, typically the nodal involvement is much higher as compared to size less than 3 centimeter. So again, size often determines neoadjuvant therapy. And I think there is also a lot of hue and cry about total neoadjuvant therapy these days. So all patients go for neoadjuvant, irrespective of whether they are resectable, unresectable, whatever they are. How do you choose the type of stent? I think, Dr. Tirumurthy, do you put metal stent at least in ADR? What do you do?
More than our this thing preference, we have to discuss with the surgeon.
Right.
Because basically, if it is borderline resectable or resectable and patient has to wait for some time, then it is the we have to discuss with the surgeon. Some surgeon they'll say a short metal stent, and once during the surgery they'll remove it. Some people say that no, we want only plastic stent, and because sometimes it may affect with the anastomosis. Based on that, we have to select the stent.
Right. I don't know what the practice at AIG is. I'm really wondering, sir.
Actually, we prefer putting in a short SEMS followed by this thing. There is a lot of hue and cry about this amount of inflammation that the plastic stents cause, but actually there is no data to show that it shows any difference between plastic stent and a metallic stent. I think metal stents are better as of today.
Right. So at least what we also do at Tata is we put metal stents. I think, sir.
Any cutoff, GV, any cutoff for you for bilirubin? 18, is it okay for you?
For us, we take 15 actually, but.
Some surgeons, in my unit, surgeons won't bother about bilirubin.
Yeah.
They say that no, don't say about bilirubin.
Same here.
Actually, more than bilirubin, it is a transaminitis that the surgeons are worried about. Actually, bilirubin is not the concern. The transaminitis, then they're worried about the thing. Actually, then they might have to put a stent in.
But I have a feeling, I've not proved. Sometimes I've seen that patient is having for longer duration of obstruction and with very high bilirubin, and probably their recovery may be slightly delayed. I have seen even after putting metallic stent, they recover slightly. So probably because of something, prolonged obstruction leading on to hepatopathy or something like that.
I think it's based on the hepatocellular dysfunction, what they expect during the intraoperative process as well as the postoperative recovery phase. So the remnant liver volume, how much it is going to function, how much it is going to gain back, and how much of dysfunction is going to reverse immediately after the surgery.
Right.
All these things plays a big role in determining at what level of bilirubin the surgeons are comfortable. Because as a surgeon, everyone will be more determined about the postoperative outcomes rather than the intraoperative procedure as such.
Right. Very true. Okay. Coming to case 8. Yeah, please.
Most oncosurgeons would probably like a stent if the bilirubin goes above 50. They would probably not want to operate. And the second problem is that even if you put the stent, you don't see the bilirubin dropping very fast. It takes a long time. It takes a very, very long time. So I think we need to discuss. It should be a multidisciplinary approach, and then discuss how long will they wait after the stent, how much is the bilirubin they want to come down. All this process has to be discussed with the multidisciplinary team.
Right.
Because I don't think the stent alone is going to be useful to bring down the bilirubin. Maybe there are other mechanisms which keeps it high.
Right.
So it's very important.
Right. Okay. Moving to case 8. This is a 60-year-old female, hypertensive, presented with progressive jaundice since 1 month. There was some dull dragging pain in the upper abdomen since 1 month. Total bilirubin of 12, albumin of around 3.4. We did an imaging, both a CT and an MR, which showed a resectable bismuth type 2 cholangiocarcinoma. What should be your next plan? Whether you will put ERCP and a metal stent? Okay, ERCP and a plastic stent. Upfront surgery. Okay, chemotherapy with neoadjuvant intent. After this. Okay. I've not pointed the answer here because this is where there is a lot of ambiguity. We did an ERCP and a plastic stent in this patient, and we all go by the bismuth classification. I think this is again something that you need to remember for hilar cholangiocarcinomas. But Dr. Vadivel, if you can take this, what about preoperative drainage and proximal biliary obstruction?
I think, so this proximal biliary drainage is something different compared to that of a distal biliary obstruction. So if you're going to put a stent in the proximal biliary tract, it's going to cause more of inflammatory changes and that thing. And then if it is going to be an operable individual, so it's always better not to touch the tumor. One thing is that we can cause tumor embolization into the vessels, which is initially operable. The next thing is going to be regarding the inflammation around the stent again, which can make the anastomosis difficult because not much of the viable duct is going to be there for the anastomosis for a hepatic jejunostomy as such. So in these individuals, I would not prefer to go for a ERCP, rather than I would subject these individuals for a percutaneous drainage.
Right. Sir?
Actually, I mean, absolutely, you're very right. Basically, because sometimes the frozen section biopsies of stent-induced changes are reported as false positives. So PTBD is always preferable to ERCP in this.
Right. So there is a lot of data again in this area to say that PTBD, at least for a preoperative proximal block, is better. But then again, at least in our unit, our surgeons, our hepatobiliary surgeons still prefer sending type 1 and 2 blocks to us for plastic stents, and of course the higher blocks will go to PTBD. EUSBD, transgastric, again, not in the
again
preoperative
similar to
setting,
that of
but
PTBD,
can be
sir.
done at least in the palliative setting, not in the, yeah.
I think USBD is not for patients who are going for surgery.
Yeah,
please.
clearly, I just said. Okay. So again, last case, case 9, 55-year-old female, biliary codex in 5 to 6 months on and off, jaundice since 1.5 months, bilirubin is around 28, alkaline phosphatase 450. There are multiple liver mets. Again, a metastatic gallbladder cancer, type 3A, maybe 4 block in this patient. What is the next step here? ERCP and bilateral stent, ERCP and bilateral plastic stent, PTBD and bilateral stent, or surgical bypass. I mean, ERCP and bilateral stent, any takers? Okay. Plastic stents. And what about PTBD and bilateral stents? Okay, quite a few. So in this case, I guess if you go by the consensus, both can be right. So which is why I've put both here. We did an ERCP and a bilateral metal stent, but then PTBD is as good and something that should be considered at least for these patients. So I mean, Dr. Tirumurthy, again, you work at Adyar, and how do you plan ERCP for complex blocks? I mean, what do you do?
Whenever we are planning this procedure for this complex stricture, we have to consider only how many levels, what is the type of bismuth classification. Even sometimes it will be multiple level of obstruction will be there. Second one, what we have to think is the functional reserve volume. If you are going to drain, how much you are going to save the liver parenchyma, that we have to do. Third one, suppose sometimes there will be multiple liver mets, then which lobe you are going to drain, that factor you have to.
Right.
Fourth one is distal, how is the distal CBD diameter? Suppose if you are going for ERCP and putting a 2 metal stents, is there sufficient space in the distal CBD to the metal stent to expand? All these factors we have to consider. And potentiality of operability, that we have to discuss in the multidisciplinary team. Right. If it is operable, always like I said, we have to go for percutaneous drainage than a ERCP for this.
Right. So you feel that, I mean, you should drain as much liver as possible, right? I mean, clearly there is data to suggest that, the more the liver that you drain, it is better. It's not just 50%. I think a lot of guidelines also mention this figure of 50%. Now, this was based on this study from France, wherein they showed, they looked at, the volume drained based on CT, and they showed that less than 50%, the survival was much lesser as compared to more than 50%. But then the logic will dictate the more you drain, the better it is. So, I mean, if you have a complex block, if you're able to drain all the segments, it is always better than draining 2 segments that are equal to 50%. Okay. If you go by the Asia Pacific consensus, I think at least for the 2013 consensus, they said PTBD should be primarily used for type 3 and 4 blocks. But then I think they came up with an update just a few months back. This is again published in Endoscopy International Open maybe 4 months back, and they said in this that even with complex blocks you can do ERCP, and PTBD or EUSBD can be an adjunct to ERCP in these patients. Again, if you look at PTBD in complex blocks, there is a lot of data. Again, they can achieve multisectoral drainage because they're able to access more easily. The issues, of course, clearly, if you have ascites, it's a problem. If you have very little IHBR dilatation, it's a problem. And again, patients may have multiple tubes. Patients may feel uncomfortable because of that. But then and there may be some amount of leak. But then again, PTBD does achieve very good drainage in these complex blocks. What about air cholangiogram? A lot of people would say you use air instead of contrast, at least for hilar blocks. There is data to say air is better, but clearly if you have a good enough fluoro equipment, right? I mean, your C-arm has to be good enough to see that air. A lot of C-arms in a lot of centers are not good enough to see the air. So if you do not have a good equipment, if you do not have a good imaging prior, I don't think air is appropriate. I mean, you can put contrast and drain the contrast. Again, I think it's already pointed out, bilateral is better than unilateral. Metal stents are better than plastic stents. Most importantly, lastly, I mean, long-term outcomes are poor, okay, across the board in malignant hilar obstruction. Median survival, even after a stent, is 150 days. So, I mean, if you're embarking on doing something adventurous, please think twice. So again, in this patient underwent 2 metal stents. We were able to drain both the segments. Patient has survived up to 6 months now, because I think she's part of a study. But then again, not a lot of patients actually survive up to 6 months. Okay, to summarize, I think it's kind of over. I think we've done 9 cases, and I'm hoping that should be enough. Okay, so again, you need a careful examination to identify early esophageal cancer. Esophageal stents used only in select clear indications. Gastric cancer needs MDT to manage, so please make sure you have a good MDT discussion. Colonic stents can be placed preoperatively, but then again, like Sir pointed out, surgeon call. En-bloc resection is better than piecemeal in colorectal polyps. Biliary drainage is not needed in all patients with OJ. Resectability has to be assessed prior. MDT to decide the preoperative drainage in proximal blocks, and most importantly, in hilar blocks, more liver drained, the better. Thank you.
I think Sridhar's team needs a bigger round of applause, a louder round of applause. Because amazing, Sridhar, your case presentation, and beautiful by the entire team here. They all did a great job. Tirumurthy, Vadivel, and Rangan, all of them did a fantastic job.
Thank you, sir. Thank you. I think before we finish, we have one more talk that was left. I think we started 20 minutes late, so we have one more talk. I think I'll invite Dr. Murli. He's going to speak briefly on hereditary cancers, that we face commonly and how to approach them. So just 4 cases, I think Murli can take over.
Thank you. We'll try to keep it as short as possible, because something which we don't again with a small quiz, which is a commonest hereditary GI cancer: FAP, Lynch, serrated polyposis, Peutz Jeghers. I'll keep the answers again. Which among the following statements is oblique or true? MSI is more prevalent in sporadic CRC than hereditary. Tumors with high MSI have poor prognosis. Presence of MSI suggests FAP. MMR deficient tumors can be diagnosed with IHC. Which of the following occurs in Lynch syndrome? Somatic mutation, germline mutation, epigenetic inactivation, all of the above. Which among the following statements is or false? The role of transvaginal ultrasound in FAP, prophylactic colectomy in Lynch, modified Spiegelman score determines upper GI surveillance in FAP, risk of upper GI tract tumors decrease after colectomy in FAP. So just to stimulate our lacunar understanding, these are the quiz questions. The outline will be along cancer and genetics, few points, particularly with respect to colorectal cancers. And what is MSI? We've been telling again and again MSI. And types of familial GI cancer syndromes. Particularly few words on colorectal and Lynch and FAP. Screening and surveillance in various syndromes. So cancer is a genetic disease. We should be all aware about that. Genetic component could be inherited or acquired. Cancer may be hereditary or sporadic. These words are all different terminologies. Inherited, hereditary, familial, they all have different meaning. Familial cancers, the persons are born with an altered genome, and the environment contributes additional genotoxic events. And sporadic cancers, the multiple somatic mutations occur due to the environment during the lifetime. So let's see what is hereditary, familial, or sporadic. We can see sporadic cancer is just, it happens by chance in 1 or 2 related family members, typically at older age. Hereditary and familial, hereditary is inherited gene changes, mutations, which are passed on from parent to the child. Familial is clustering of cancer in a family, can be due to genes and oblique or some environmental factors and lifestyle. Typically a geographical area or a family, those kind of things. So genes involved in carcinogenesis, you can see a busy slide, which is very simple. There are 3 types of genes: proto-oncogenes, tumor suppressor genes, and DNA repair genes. The proto-oncogenes, like KRAS, they are all growth factors, everything for growth. And here the mutation is a gain of function mutation. The patients develop gain of function mutation, so it gets upregulated. So the growth gets enhanced. Here the tumor suppressor genes, they are primarily for inhibiting the cell division. They play a role in apoptosis and they protect against cancer. So here they are all called gatekeeper genes. And loss of function mutation is the one which is a problem here. Typical P53 and APC, since we are talking with regards to colorectal cancer. And we all know about the Knudsen's 2-hit hypothesis. The last one is the DNA repair genes. They maintain the genomic integrity of the cell. And the typical, they are called caretakers. And the most important among them is mismatch repair genes. And they are the one which are involved with microsatellite instability, MSI. So here also loss of function genetic event happens. So if we can't remember, these are the few things which you should remember. Tumor suppressor, protect against cancer, APC, 2-hit hypothesis, DNA repair, genomic integrity, mismatch, this particular gene, and microsatellite instability. So colon carcinogenesis, it happens in 2 stages. One is formation of adenoma, it's called tumor initiation. Second is progression from adenoma to carcinoma, it's called tumor progression. It happens in 2 pathways. One is chromosomal instability, the other one is microsatellite instability. So as you can see here, 85% of all CRCs are due to chromosomal instability, typically like APC mutation, not necessarily inherited or familial. So they are all called microsatellite stable tumors, called MSS. The minority, 15%, can happen due to microsatellite instability. This is called MSA pathway. This happens due to the MMR gene mutations. They are called MSA tumors, microsatellite CRC. So the molecular events can be due to either genetic or epigenetic. Epigenetic means other than genetic, above genetics. So it's like epithelium, epidermis, epigenetic. So in the genetic, as I told, it can be this APC or MSA pathway. In the epigenetics, it would be this methylation-induced gene silencing, those kind of things. So APC pathway, we know it's from normal, it starts becoming early adenoma, late adenoma, finally carcinoma. This is a typical adenoma carcinoma sequence. MSA pathway, as I told, mismatch repair genes, all this MLH, MSH, these kind of things. So here we have all the MSA pathway and it leads into carcinoma. It's a totally different pathway. So what is MSI? What, when, and why? MSA is nothing but loss of this mismatch repair gene activity. This again can be due to 2 ways, mutational or, as I told, epigenetic. Mutational happens in germline mutation. So this is where our syndromes come, HNPCC, Lynch. And epigenetic happens in a local event, in that particular cell in that colon. This germline will be there in all the cells in the body. So germline mutation, if you test the blood sample, you can pick up the germline mutation because it is transmitted from the parent to the child. But this is a somatic mutation. It is happening in that particular organ, particular cell, so it's a local event. So these rise to sporadic MSA. So how do we test for this MSA tumor? We can either test by PCR method where you can take the tumor tissue and test for PCR, or you can do an immunohistochemistry of the biopsy sample, which we send endoscopically. So the terminology used is MSI or MSS, where microsatellite instability or stable, depending on the report. Here we use the word MMR deficient or MMR proficient, based on the immunohistochemistry. So this is a typical PCR picture of MSI report will look like. They check with 5 nucleotides. This is how the report looks. If 2 or more are positive, then we give the report as positive MSI. And the IHC will look like this. Here you can see we are taking up staining. Here there's no stain. Whatever small stain here, it's the internal control. And these are all MSI by IHC method. So now we know what is MSI, how do you test for MSI. So based on that, typically when we take a sample endoscopically and give it to the pathologist, after confirming the colorectal cancer, they will do the IHC and they look for these 4 genes, 4 proteins. If there is no loss of these 4 proteins, then they label it as a MSS, microsatellite stable tumors. And if there is a loss of one of these, depending on the loss of which protein, here MSH2 or MSH6, straight away we suspect the HNPCC. Other 2 we have to do further testing. It can be still sporadic or MSI. For that, we need to know how to differentiate. There is an interesting epidemiological fact. What is it? There is a mutation called BRAF mutation, and for some unknown reason, it is never ever observed in HNPCC. So next step what we do is a BRAF mutation. If it is present, then it rules out this HNPCC. We go for sporadic MSI. And also there is another thing. If there is no BRAF mutation, that doesn't mean that straight away you conclude that it is HNPCC. Still, the next step is we need to look for promoter hypermethylation. And in this step, if it is there, we have to conclude it is sporadic. If it is not there only, we have to suspect HNPCC. To confirm, we have to subject the patient to germline mutation. So I'll tell again, this is very important because as gastroenterologists, we forget after taking a biopsy, what happens to the patient, we never bother because the patient goes into the oncology department. But this is what is happening behind the scenes in all the patients. They do immunohistochemistry of the biopsy sample and they look for these 4 proteins. If none of them are there, then it is MSS tumor. If these 2 are there, then they suspect HNPCC and they send for germline mutation analysis. If these 2 tumors are there, proteins are there, then they need to do this BRAF and promoter hypermethylation. These are all being done. So this is what I've been telling. All patients with CRC, if the tumor tissue is available, either we do a IHC or this MSI by PCR method. And if it is abnormal, then we check which proteins. If these are the 2 proteins abnormal, then straight away we check for germline mutation. If it is pathogenic, then we can label it as Lynch. Why are we taking so much of pain? Because the guidelines are different, strategy is different, treatment guidelines are different. And if these 2 proteins are absent, then we need to check for the BRAF and promoter hypermethylation. So when to test for MSI? Initially, they were putting criteria like Amsterdam criteria or this Bethesda guidelines, everything. But now, tumor testing for DNA mismatch repair is done in all CRC patients. This is a revised Bethesda guidelines. So why are we testing for MSI in CRC? Number 1, this is a method we can screen for Lynch. We cannot do germline mutation for all CRC patients. And second thing is it has got an independent prognostic value. The MSI positive tumors, they show better prognosis than MSS tumors, that is stable tumors, particularly in stage 1 and stage 2. And there is a lower rate of lymph node and distant metastasis, particularly in stage 3 and 4. And MSI tumors, they show differential response to chemotherapy. And they are sensitive to immune checkpoint blockade. There is a new group of drugs, armamentarium with medical oncologists, and these MSI tumors are sensitive. And we can see the algorithm, the grade 1 and 2, low risk, grade 3 and 4, they do the IHC, and if it is MSI, it falls under low risk. If it is MSS, they go into high risk. particularly if it is BRAF positive, it is an extremely high risk. As I told repeatedly, the therapy predictive implications of MSI, 5FU is ineffective in stage 2. So when you give 5FU for all the patients, we should know in the back of the mind that we are giving those side effects for nothing. So no chemotherapy will be useful for MSI positive tumors in stage 2. And oxaliplatin is effective, so combination regimen will be used in stage 3. Other thing is, these MSI tumors are unstable and hypermutational, so they have a high expression of checkpoint proteins. So all this immune therapy will be very useful, particularly in metastatic disease. These are the chunk of people we commonly see in our society, people coming in a late stage. So we should be aware of these things. So the implications of MSI, majority of MSI in CRC are still sporadic, as you can see. And it happens due to promoter methylation. It's a favorable prognostic biomarker. So Lynch syndrome, CRC is standalone. That tumor is a low risk, contrary to our usual understanding. And the predictive role for assistance, as I told, is there. They show good response to immune therapy. So having finished these two things, I'm not going to talk on hereditary gastric or pancreatic cancers. These are the proportion. Sporadic, as we know, is a 70%. Familial is only 25%. The remaining 5% is a hereditary. So we should know the difference between familial and hereditary. The hereditary, we have non-polyposis and polyposis. Typically, in non-polyposis, we have a lot of syndromes. The main is a Lynch syndrome. In polyposis, we have a lot of syndrome, which is FAP. I'm not going to talk on all these things. Lynch, most common hereditary CRC syndrome, autosomal dominant, defect in MMR genes. It's a case of accelerated tumor progression. Remember, I told two things, tumor initiation and tumor progression. This is a case of accelerated tumor progression. And here we have MSI, and it will be detected by IHC techniques. The cancers mainly are colorectal and endometrial. It also happens in other organs, as mentioned here. And you can see it's more proximal and mucinous histology. So for a poor man without IHC, if there is a mucinous histology or right side tumors, we should have a suspicion for these things. FAP, again autosomal dominant, we have tens and thousands of adenomas. It's APC tumor suppressor gene mutation. Here it's an accelerated tumor initiation. So the polyps occur in adolescents and young adults. Lifetime risk is more than 90%. And after colectomy, the other second common tumors are duodenal and ampullary adenocarcinoma. That's why they need a upper GI surveillance. So comparing a FAP with sporadic, each adenoma in FAP, this is a very interesting fact. Each adenoma in FAP display a normal progression to carcinoma in like normal people. Because the problem is not with tumor progression, it's only with the tumor initiation. And the sporadic adenomas, they needed 2 somatic mutations, but here already there is a pre-existing 1 mutation, so
Dr.
the
Murli?
chances of happening...
I think we're short of time,
okay,
so...
Right. I'll just come to the strategy. Lynch, we need to do a colonoscopy. For uterine, we need to do a transvaginal ultrasound and endometrial biopsy and upper GI endoscopy. For classical FAP, we need to do a sigmoidoscopy, and if the adenomas are there, we need to do a colonoscopy. And so the same 4 questions. Commonest hereditary GI cancer syndrome. Anybody can answer? Lynch. Thank you. Which among the following statements are true? One, two, three, four, more than one. MSI is more prevalent still in sporadic. MMR deficient tumors can be diagnosed with IHC. These are the 2 correct answers. High MSI, better prognosis. Presence of MSI suggests Lynch than FAP. Which of the following occurs in Lynch syndrome? Germline mutation. We may be tempted to say all of the above, but it's only the germline mutation. I've been repeatedly telling we need to check for germline mutation. Which among the following statements are false? I told transvaginal ultrasound is advocated in Lynch because we have endometrial CA. So the one is wrong. Prophylactic colectomy is in FAP. And risk of upper-GI tumors still persists after colectomy. So the right answer is modified, which we didn't cover. Okay, so the take-home messages are oncology is intrinsically linked to genetics. So when we try to understand gastro-oncology, we cannot run away from genetics. We need to understand genetics. The importance of MSI tumor, I think we all need to go and upgrade our knowledge regarding what is MSI, because it is happening. The prognosis, treatment, everything depends on that. And sporadic versus familial GI cancer, the implications are different because we need to understand the screening and surveillance strategies, which give survival advantage. Thank you.
Thank you, dear moderator and panelists, for the extensive discussion in oncology. Due to lack of time, we will not be taking up questions. The next session will be clinics in endoscopy. The theme is pancreatic fluid collection. It will be a case-based discussion on acute necrotizing pancreatitis. For this session, I would like to call upon Dr. Matthew Phillips sir, Dr. G.V. Rao sir, Dr. Palniyappan sir, Dr. Vishnu Abhishek sir, Dr. Ilangovan sir onto the